Bore da, a chroeso i bob un ohonoch chi i gyfarfod ein bwrdd ni heddiw, bwrdd iechyd addysgu Powys. Ac fel y gwelwch chi, yn ôl ein harfer, mae'r cyfarfod yn cael ei ffrydio yn fyw drwy wefan y bwrdd iechyd. Ac bydd recordiad o'r cyfarfod hefyd ar gael i'w wylio ar-lein ar ôl y digwyddiad heddiw. Yn enw I ydy Carl Cooper ac fi ydy cadeirydd bwrdd iechyd addysgu Powys. Ac yn y man, fe welwch chi ar y sgrin fanylion yr aelodau a'r bobl a'r mynychwyr ychwanegol fydd yn bresennol yn y cyfarfod heddiw, yn ogystal â'r rhai sydd yn methu bod yma a dyn ni wedi derbyn eu ymddiheuriadau am absenoldeb. It's a great pleasure today to welcome you, as always, to today's meeting of our board, the Board of Powys Teaching Health Board. And as we always do, we are live streaming the meeting today via the Health Board's website, and a recording of the meeting will be available to view online after today's event. My name is Carl Cooper and I'm the chair of the board, and you'll see on screen in a second or two the details of board members and additional people who will attend today's meeting. And as well as that, you will also see that we do have some colleagues who can't be with us today. They have given their apologies. We have received their apologies for absence. Felly, beth ydyn ni, ynde? Be di pwrpas ni fel bwrdd? Wel, ni ydy corff llywodraethu y bwrdd iechyd, ac dyn ni'n cynnwys aelodau annibynnol yn ogystal ag aelodau gweithredol. A chyda'n gilydd, dyn ni'n ffurfio bwrdd unedol, a dyn ni'n gyfrifol yn benodol am 4 peth. Yn gyntaf, dyn ni yma i osod cyfeiriad strategol ar gyfer ein sefydliad. Yn ail, dyn ni yma i osod yr awydd i gymryd risg wrth gyflawni ein hamcanion strategol. Yn drydydd, yn bwysig iawn, dyn ni yma i fonitro cyflawniad a pherfformiad yn erbyn yr amcanion strategol hynny. Ac yn bedwarydd, ac yn sicr nid yn lleia, achos mae'n holl bwysig, dyn ni yma i osod ac i liwio ac i fodelu naws a diwylliant ein sefydliad. Our purpose as a board is fourfold. Firstly, we are here to set the strategic direction for the organisation. Secondly, we are here to set the risk appetite in connection with the delivery of our strategic aims. Third, we're here to monitor delivery and performance against those strategic aims. And fourthly, and certainly not least, because for us it is hugely important, we're here to model and to set and to shape the tone and the culture of the organisation. We are the governing body of the Health Board, and you will see that we are made up of both independent members and executive members, and together we form what we call a unitary board with those responsibilities. Now, we meet in line with the NHS Wales regulations, and I think it's important to point out that this isn't a public meeting. However, it is a meeting that is held in public. So the only people that will participate in the meeting are the members of the board and those invited participants. And so we don't have direct participation from the public. However, we do invite questions and feedback from the public. And if you look on our website, you'll see more information there about how that feedback can be sent to us, or how those questions can be submitted for our consideration in our board meetings. We are being live streamed via Microsoft Teams, And as I said earlier, the website will be available very shortly after today's meeting. We've got a lot to get through today, and so today's meeting will be quite a long meeting, so we will be taking breaks at certain points during our meeting, and we will have a lunch break at around about 1:45. But without any further ado, dwi eisiau symud rwan at yr agenda go iawn, ac fe welwch chi copi o'r agenda ar papurau ar ein gwefan. Our agenda and the papers for today's meeting are published on our website. They are publicly available, and so please do access them there, and you'll find there all the information that is available to us as board members for our meeting today. So without any further ado, we're going to move to item 1.2 on our agenda, declarations of interest. In our papers, we have our register of declarations of interest, and so they are publicly available, they stand. I will ask members, are there any additional declarations of interest that anyone would like to mention in relation to any item on the agenda? No, there aren't. Helen, I can see you want to come in. Please do.
Diolch, Carl. Helen Bushell, Director of Corporate Governance. Good morning, everybody. Carl, I just have a declaration to make on behalf of the whole board. We will be considering our annual report and annual accounts today, and within there is remuneration detail about all executive and non-executive members. So I just make that declaration on behalf of everybody to note. Carl, if I may, we had a slight technical difficulty earlier on. Members that were joining the board appeared, but those sending apologies didn't. So just to confirm for the benefit of anybody watching, Robert Lewis and Simon Wright have sent apologies today, both independent members. They are on annual leave. Katie Blackburn, the regional director from Llais, was due to join us, but unfortunately has had some technical difficulties, so hasn't been able to access the meeting for that reason. Thank you.
Oh, thank you, Helen. Really helpful. So there are no other matters in terms of declarations of interest. So we go to item 1.3 and our board action log. And Helen, would you like to make any comment against anything on the action log?
Diolch, thank you very much, Carl. So there are just 3 open actions on the log. None of them are due for this board meeting. 2 are for September. 1 is for March. Sorry, all 3 are for September. My apologies. And all are on track to come to the September meeting. So nothing further to add now.
Helen, please forgive me if I'm raising this in the wrong place, but I know that in your report at the last meeting, perhaps a couple of meetings, reference has been made to the professional forum and the terms of reference, and it's not included as an action, and it may be, as I say, that I'm asking this question in the wrong place, but it would just be helpful to know where we are with that and how we are keeping track of that particular action.
No problem, Carl. And if agreeable to you, I'm very happy to give an update in my Director of Corporate Governance report, if that's okay.
Lovely. Okay, thank you. Colleagues, anything else on the action log? No. So we move to item 1.4, and as always in our meetings, we have both patient experience stories. Now, we don't have a patient experience story today, but we do have a staff experience story. These are really important because, if you like, they help us to bring alive the information and the data and the intelligence that is often brought to us as a board, and to make it real. And so I'm really pleased today that we have with us Becky Baldwin, but I'm going to hand over to Deb, our Executive Director for People and Culture, who will introduce Becky to us. Thank you, Deb.
Diolch, Chair. I'm absolutely delighted to be able to introduce Rebecca Baldwin, who is a team leader in the district nurse team in Llanfethlin, and she has joined us today to share her staff experience story. I first met Becky during our reverse mentoring sessions, And from day one, it was clear that her dedication and passion for the role of community nursing runs through her DNA. I was privileged to see this at first hand when I was invited to walk in Becky's shoes for one afternoon, and had the opportunity to meet a few of our wonderful patients and their families who were receiving much of their support for their palliative care needs in their home settings. I won't steal any more of Becky's thunder. I'll hand over to you, Becky. Thank you.
Thank you very much, Deb. Well, good morning. Thank you for the opportunity to share my board story. Next slide, please. My name's Becky. I'm a 35-year-old wife to Ed and mum to Oscar and Hetty, and I'm also the deputy team leader within the Llanfyllin community nursing team. It would seem that I've now become a keen gardener. I particularly like growing vegetables, and I do like to exercise. I've realised that running with a mum friend ensures I stay both physically and psychologically balanced. Next slide, please. It really was always going to be nursing for me, and I knew from the age of 12 that I wanted to be a nurse. My desire to be a nurse was strengthened by the exposure I had to the careers of my mum Rachel and my godmother Gwennan, careers I followed with interest and admiration. My mum genuinely enjoyed her job as a radiographer, and I often used to think that being happy at work had to be a priority because you spend so much time there. Mum's career highlighted that within the NHS there was opportunity for progression alongside a work-life balance. Mum finished her career as a well-respected team manager. She was the superintendent radiographer for North Powys. In 2005, I spent my Year 11 work experience with Gwennan, a community specialist palliative care nurse. We spent the day visiting patients with palliative care needs, and it was an eye-opening day for me at the age of 15, being around people in their last days of life. Gwen has been a wonderful support to me throughout my time studying and working as a nurse, and it was an honour to work alongside her caring for patients in the Llanfyllin locality before she retired. So, in September 2008, I took up position as a student nurse based at the School of Nursing and Midwifery at the Wrexham Myler Hospital. And in 2011, I qualified with a first-class honours degree in adult nursing. Next slide, please. And then, on Monday, the 17th of October 2011, it all began. I started my first nursing job at Ludlow Community Hospital on Stretton Ward. This was a care of the elderly rehabilitation ward serving the residents of South Shropshire. My 18 months on Stretton Ward, led by a fantastic manager, gave me the opportunity to learn the fundamentals of nursing, how to really look after a person. I learned the importance of good nutrition and hydration, consistent sleep, and effective skincare, as well as the need for physical and social rehabilitation. Recognising that I needed to move into the acute secondary care centre and having taken an interest in patients with cancer, I moved to Ward 21 at the Royal Shrewsbury Hospital in June 2013. This 16-bedded specialist ward provided inpatient chemotherapy. In September 2019, having returned to work following the arrival of Oscar, I quickly realised that my priorities had changed. The work-life balance needed to alter. 12-hour shifts and night shifts were not conducive to life with a small child, and I was fortunate to secure a community staff nurse position with the Llanfyllin District Nurses. Next slide, please. Before I move on to discuss my current role, I wanted to mention the postgraduate study I have done. And honestly, it's not to show off, but it's because I feel really strongly that nurses do need to be highly educated and up to date with best practice. The significant shortage of doctors within the United Kingdom has meant nurses have had to upskill. Nurses are performing the role of a junior doctor across many disciplines. For example, in GP practices as advanced nurse practitioners, and within oncology clinics seeing newly diagnosed patients and prescribing their chemotherapy regimes. None of that possible without a considerable amount of study. The first formative study I completed after qualifying was a degree-level chemotherapy and cancer care module, which I completed in person at the Royal Marsden Hospital in London in 2014. Between 2020 and 2022, I completed the Specialist Practitioner qualification at Wrexham University, required in order that you can officially be recognised as a district nurse on the Nursing and Midwifery Council register. In 2023, I enrolled back with Wrexham University to complete my Masters in Health and Social Care. For 8 months, I focused a 15,000-word dissertation on the importance of clinical supervision to prevent compassion fatigue and burnout in nursing. My current study has involved reverse mentoring with Deborah Wood-Lawson, the Executive Director for People and Culture. We have met regularly online and in person throughout the year, and Deborah has offered advice and support, signposting me to opportunities and training which are beneficial as I start my journey in management. At the end of May, I attended an executive meeting alongside the Chief Executive and Executive Directors. It was an invaluable experience, giving me an insight into the wider picture of the organisation, whilst I also realised the difficult decisions that are required to ensure balance in the books does not compromise patient safety. Next slide, please. My current role as the Deputy Team Leader within the Llanfyllin Community Nursing Team involves providing nursing care to patients who are housebound. We are a rural team, and it is nothing to cover up to 60 miles per day and only see 5 patients. The services we provide include the treatment of acute, chronic and trauma wounds, leg care, maintenance through the supply of compression stockings and the completion of Doppler assessments, palliative care, care of central venous access devices, injection administration including insulin and vaccinations, and pressure sore prevention, which is the regular monitoring of patient skin to prevent pressure damage. On Tuesdays and Fridays, we run a clinic from the surgery here in Llanfyllin. Most of the patients we see are those who are not housebound, but who have chronic leg ulcers. On Wednesdays, my afternoons are spent getting on top of my to-do list. The management side of the job, which involves DATEX reports, completing the next rota, and checking what mandatory training the staff need to complete in the coming weeks. On a Thursday, I attend the weekly GP multidisciplinary team meeting. We discuss patients with acute needs, and it is an effective way to refer to the appropriate service. There's an agreed accountability on who will action the required care. Having worked now within the community for 6 years, it is clear to me that caring for people in their last weeks, days and hours of life is where my passion really lies. I feel privileged that I can do this aspect of nursing because I am aware it's not for all. Next slide, please. It wouldn't therefore feel right for me not to include a slide about the palliative care services we deliver as a team. Caring for patients with palliative needs is estimated by the Queen's Nursing Institute to make up 40% of a district nurse's workload. For our team, some weeks it can be 80% of our work. The high percentage of end-of-life care delivered by the Llanfyllin district nurses is due to the team having the greatest number of patients over 75 years old on the caseload in comparison with other Powys district nurse teams. Age demographic, we have a caseload more likely to be entering the final years of their lives, in addition to having a vast number of our patients who live more than an hour and a half from a hospital or hospice and therefore make the decision to stay at home for treatment and care. When we are first asked to visit a patient who is entering the last weeks of their life, usually by the GP who has confirmed their wish to stay at home for end-of-life care, we visit promptly. I introduce the district nurse service as the hands-on, practical support. I take time to get to know the patient, the family and the home setup. I find myself always subtly assessing, checking, where will the hospital bed fit when it is needed? What help will this family need to ensure this patient can stay at home to die? Is the patient or relative holding something back? I often hope that the husband or the wife will follow me to the car as I leave, and it will be there that they tell me their concerns. Worried they won't do a good enough job, worried about being alone when their loved one dies. Visiting regularly allows us to build a trusting rapport with the patient and the relatives, and gently we can talk about the patient's decline and how the coming weeks and days may look. We work closely with the community specialist palliative care team, who offer specialist advice, support, and a direct link with the palliative care consultants based at Severn Hospice. And as the patient enters the terminal phase of their life, we will, as needed, administer medication to relieve any symptoms using a syringe driver. The final part of our role in providing end-of-life care is to perform last offices. This maintains the patient's dignity, ensuring they are clean and comfortable, allowing the relatives to sit with them for as long as they wish. Next slide, please. Thank you for your time and for listening. I wanted to include this final picture as I took it last week when I was using my wellbeing break for a short walk following a visit to a patient who lives right by Lake Vyrnwy, and it made me think it really isn't a bad place to work. I hope the passion and enjoyment for my job and the care of community patients has come across. Thank you.
Becky, it's us that should say a very, very big thank you to you. I just love the way in which you shaped, crafted, and presented the information you've shared with us today. You started with you as a person, which is really important, isn't it? And we all have jobs, we have roles, and so on, but actually we're all ordinary people living ordinary lives with families and so on. And then you absolutely shared with us your journey, your passion, your enthusiasm, and the whole purpose of these stories, as I said earlier, is to make it real. And you've definitely done that. And so a big thank you. Now, we don't necessarily open these stories to discussion or debate or questions and so on, but we do allow just a minute or two for any particular observations that one or two board colleagues may have. And I can see that Claire wants to come in, but colleagues, if there are any others, then we do indicate. Claire, please do.
Diolch, Chair. Good morning, everybody. Claire Roach, Executive Director of Nursing Quality, Women and Family Health. Becky, I want to say a huge thank you today for sharing that story. You did make me smile when I saw the boot of your car, and it absolutely brought back memories when I was a community midwife, and one side of the car would have had my kit bag and the other side had the football kit. So I completely related to that. But in particular, I really wanted to thank you for the way in which you presented that, and that you demonstrated the breadth of the profession of nursing. And last year in 2024, the Royal College of Nursing revised its definition of what it is to be a nurse. And what they say is that nursing is a safety critical profession, and it is founded on 4 pillars, which are clinical practice, education, research, and leadership. And you totally demonstrated in that presentation the fact that we are highly educated professionals that have to continually update ourselves throughout our career. And for me, you also demonstrated the 4 pillars of the Code of Conduct of prioritising people, preserving safety, practising effectively, and promoting professionalism. So, on behalf of all of the nurses in Powys Teaching Health Board, thank you for really being an excellent representative and an advocate. Diolch.
Thank you, Claire. Thank you.
Becky, thank you so much for your time today. As I say, what you have shared with us will resonate in our minds and in our hearts for a long time, and will certainly influence how we think and how we view things. And for that, a big thank you. Diolch yn fawr.
Thank you very much. Thank you.
So thank you for that. And we move now to item 1.5 on our agenda. I mentioned earlier that we always invite questions from the public to be considered in our board meetings. We haven't received any questions from the public for this meeting, and therefore there is nothing to consider against this agenda item. So we move on to item 1.6 and to the update reports. Initially from me as chair, I'll take the report as read, but I am happy to ask for people to ask any questions or pass any comments or observations in response to the report. Does anyone want to do that? I can't see that anyone does, so thank you. We move then to the Vice Chair's report, and I'll invite Kirsty to offer any additional comments that she may have. Thank you, Kirsty.
Thank you, Chair. I'll take the report as read, but as the Chair has just indicated, happy to take any questions or receive any comments colleagues may have this morning.
No, everyone is very content with your report, Kirsty. Thank you very much. So we move to our Chief Executive's report. And Hayley, do you have any additional comments, please?
Thank you. Just a couple of points to note for colleagues. So in terms of the information regarding the emergency medical retrieval and transfer service and the judicial review, yesterday we received information that the permission to appeal has been refused on all grounds. So that is a material change to the report that we were informed about yesterday. So I wanted the board to be made aware of that. Secondly, the position regarding Swansea Bay University Health Board maternity services update. I just wanted to offer Claire Roche as our lead an opportunity just to provide assurance to the board about how we're responding to the publication of the independent review into maternity and neonatal services at Swansea Bay University Health Board. Thank you, Claire.
Diolch, Hayley, thank you. So on publication of the Swansea Bay Maternity Services report on the 15th of July, we obviously reviewed that report to assess the recommendations. There were a number of key areas of focus in that report, particularly on clinical findings from detailed case reviews, staffing and leadership and governance. And the recommendations were partly for the Health Board of Swansea Bay, but also there were recommendations for Welsh Government. As a result of that, the Cabinet Secretary has announced that there will be an All Wales Assurance Assessment for all maternity and neonatal services in Wales. And as an Executive Directors of Nursing peer group, that information was shared with us at a very early time, which has enabled us to be able to prepare for that self-assessment that we will all undertake in our maternity services. And within PTHB, we have already commenced that work. I also want to assure the board that for any women and families that have been affected by this report, or indeed maybe accessing services in Swansea Bay, we have been targeting our communication with them via their named midwives. Thank you.
Thank you, Claire. Just a final point of information to the board. Claire is obviously retiring later in the year, and I'm very pleased that we've made a appointment to the Executive Director of Nursing, which will leave us with no gap. The individual will be starting in September, and that individual is called Paul Hooton. So just wanted the board to be aware of that. Thank you. Any questions, Carl? Thanks.
Yeah, thank you, Hayley. Just picking up on the maternity matters, in your report, Hayley, you say that we'll provide more detailed reporting through our own internal reporting structures and keeping the board informed. Just wonder whether it might be worth just clarifying, how that will happen. So will it go to a particular committee? How will we as a board keep sighted on the learning and the implementation of that learning?
Absolutely. The specific committee we'll be reporting through is through to the Patient Experience and Quality Safety Committee in the first instance, Carl, and then obviously by exception through to the board.
Thank you. So Jen, please come in.
Diolch yn fawr. Jennifer Owen Adams yw fi, independent member, Powys Teaching Health Board. Hayley, thank you very much for your report. I just wanted to ask you a little bit more about the Hywel Dda University Health Board Clinical Services Plan consultation. Thank you very much for the update that you've given us. And you've said towards the end of that section that if we wanted even more detailed information about that, we can go to that. I'm just wondering in terms of the timescale of that consultation. I think it's due to end. I think you're saying around by end of August. So when can we expect to hear any sort of formal or the next stage of those proposals? I'd be grateful for just an update on that. Thank you.
Yeah, thank you, Jen. So there will be a process that Hywel Dda Health Board will need to undertake to take on board all of the insights that they gain through the engagement and consultation processes that they've had. And as part of that, they will share with us in particular any insights that come from the Powys population, which will inform then it coming back to our board for consideration. My understanding is I'll have to check the exact timescale for that, but that will take probably a couple of months after the closure of the consultation with them to do the due diligence work on that. So I will double check the timetable so I can share an exact date, but at that point we will bring it back as soon as it's available from Hywel Dda for consideration by our board.
Thank you. So we go now to Mick. Please, Mick.
John Chair, my name is Mick Janassi. I'm an independent member. Can I just go back to the maternity issue? I did have a number of questions, but Claire answered one of them and Carl, you covered the other one about future reporting. The one that wasn't answered was around our commissioning oversight. So I just wondered whether we were going to strengthen our commissioning oversight just to ensure that, the services provided for Powys residents are provided safely and compassionately.
Thank you, Mick. Claire, would you like to come in on this point? Because I think that there are a couple of points just in introduction that I would like to make is that the board will be receiving at its next meeting an updated strategic commissioning framework that actually draws together how we undertake our commissioning arrangements and oversight in the health board. We have always had very clear arrangements in place to link with all of our individual providers, and clearly the history around this with both issues that we faced in Shrewsbury and Telford NHS Trust and also in Cwmtaf Morgannwg. We've had very strong arrangements to both oversee and actually be involved in understanding the progress on some of these improvements. But I just wondered, Claire, if you wanted to particularly come back in on the work that you've been leading. Thanks.
Yeah, thank you, Hayley. So, Mick, I guess there are a number of ways in which we have that oversight. So we have that oversight through the commissioning arrangements with the commissioning team through the CQPRM meetings that our quality team are also involved with. But we also have direct liaison and communication in terms of both an executive director of nursing to executive director of nursing perspective, and also our directors of midwifery to directors of midwifery. So you'll be aware that we have recently appointed into a director of midwifery, women and family health. That is the first time within Powys Teaching Health Board that we've had that role. And that's absolutely strengthened our leadership because we do still maintain having a head of midwifery role within the organisation. So we have multiple ways in which we can directly communicate and liaise in a very formal, structured way between the directors of midwifery in Powys Teaching Health Board and the directors of midwifery and heads of midwifery in each of the organisations that we commission. In addition to that, we have a number of really important national peer groups. So we've got the Directors of Midwifery Advisory Group, in which all of the Directors of Midwifery sit on that group in terms of shared learning and oversight. And they report directly into the Executive Director of Nursing. I currently am the lead Exec Director of Nursing for maternity and neonatal. So I have a sort of a unique privilege at the moment to be involved in the maternity and neonatal safety programme, which enables me to have, I suppose, oversight in an even more unusual way than I would do normally. So I hope that gives you some insight, and I'm happy to pick up any further conversations outside of the committee.
You content to make? Yeah, okay.
Yes, thank you.
Thank you. Ronnie, please.
Thank you. Good morning. Ronnie Alexander, independent member. Hayley, I would just like to thank you for your report as always. I find it very interesting. Predictable question from me, perhaps, on RSV vaccination. Given the importance of this campaign for the two cohorts which are specified and the dual method of administration, are we confident that we can deliver this programme in time against the expectation which has been set for us? And in asking that question, I would say that I have deep respect for the vaccination team and for the important public health work that they undertake on a daily basis. Thank you.
Thank you, Ronnie. A really important question, and I'll ask Mez to come in to respond. Thank you.
Yeah, thank you, Ronnie. Bore da, Medaria Bowley, Director of Public Health, and apologies, my voice is a bit croaky today. So, yeah, absolutely. In terms of the RSV programme, it is a new programme that was introduced last September, and delivery is split between GP practices and the vaccination service in the Health Board, and also the maternity service also offered to pregnant women. In terms of uptake, it's not where we want it to be at this stage, but we have implemented an improvement plan and are working with those GP practices which are participating in the programme and also doing targeted outreach work with the aim of reaching 70% target by the end of September. End of August. I am pleased that actually for about 6 or 7 GP practices where the Health Board are supporting or doing the catch-up, we have already reached past 70%. Average uptake currently is at 62.7%. So we'll continue to do that outreach work during the next 4 weeks. Just also to highlight the great work of the maternity team for pregnant women, uptake is above 60%, and that's been continually above 60% for the last few months. And there are lessons being shared across Wales around that model as well in terms of good practice. I hope that helps, and apologies again for my voice.
Ronnie, you content?
Thank you.
So finally, in response to Hayley's report, we'll invite Chris to comment before moving on to our next agenda item. Thank you, Chris.
Thank you, Carl. Councillor Chris Walsh, Independent Member, Local Authority. Thank you, Hayley, for the report. It's really helpful, as it's been mentioned. In relation to the Swansea Bay maternity service review, a question on that is, were there any Powys patients affected from that review that we're already aware of, and how has that been managed in communication with them? I know Claire had mentioned going through the maternity team, but I just wanted to just ensure there's no additional risks to them. And then in relation to the clinical service plan consultation by Haldar, and also Nairn Bevan's enhanced local general hospital review or future model, does that have any implications to our Better Together? I know we've got that as an agenda item separately, but it'd just be useful to understand whether that's influenced any of the scenarios we've been considering at this early stage in that development.
Thank you, Chris, and thank you. Really important questions. And just to loop back to Jen's point earlier, currently the timescale for reporting on the clinical services plan that Hywel Health Board have set is November board for themselves, but that will be subject to both the scale and volume of the responses that they need to analyse. So I will bring an update to the September meeting just to confirm the ongoing timescale and when we'll be bringing that back back to the Health Board for consideration. The issue around the clinical services changes, at the moment I'm highlighting live consultations and engagement that are taking place in my report, but that is one of the key issues we have to manage around understanding what are the changes to neighbouring health boards and trusts plans, and what does that mean in terms of pathways of care for our population in Powys. So I can give you assurance that we assess that, and we have a strategic change report coming through to the planning committee regularly to appraise on all of the changes that are being proposed around our borders. But clearly at the moment these are options, so we're not really able to build a preferred option into our thinking, but it is very much a formal part of checking in on that and taking into account any proposed changes in how we would need to adapt our service model in Powys. And that's a very live, ongoing piece of work, Chris. And so to give you assurance that we will continue to plan and take into account any changes as they move forward with their engagement and consultation. In terms of the point that you raised around maternity services, it is important that I probably bring Claire back in, because I think it's the level of detail you're requesting is making sure that we're having the right conversations and to what extent that has impacted on women in Powys. So I'll ask Claire to come back on that point. Thanks.
Yeah. Thank you, Hayley. Chris, in terms of the detailed case reviews, we've not been advised that any of those related to Powys families, but clearly we are ongoing in our discussions with Swansea Bay about any potential impact, and clearly that would involve individual cases. So, you know, I wouldn't share that here, but in terms of the detailed case reviews, I can advise no.
Okay, thank you.
Thank you all, and Hayley, thank you once again for a really helpful and informative report. Much appreciated. So we go on to consider now the reports from our board committees, and I think it's always worth explaining that that our public meetings, such as today, are really important meetings, but as a board, a lot of work happens outside of these meetings, and very, very importantly, in our subcommittees. It's in our subcommittees where we do the detailed scrutiny work that is the particular remit of the respective committees. And so we're going to go through those committee reports one by one, and the chairs of those committees, who are all independent members of the board, also have an important role in being both the custodian and the conduit of the assurance from those committees to us as a board. So I will invite the chairs of those committees to present their reports and to highlight anything that they would like to bring to our attention. So we go firstly to ARAC, to the Audit, Risk and Assurance Committee, and to Steve Elliott, its chair. Thank you, Steve.
Thank you, Chair. Good morning, all. I'm Steve Elliott, the Independent Member for Finance. So the report covers 3 meetings, but I did give a verbal update at the last board on the meeting held on the 13th of May. So I'll just concentrate on the highlights from the meetings held on the 17th of June and 8th of July. In both of these meetings, we did consider progress on the annual accounts, but this is covered later in the agenda, so I'll pick that up later on. We received the hosted body annual report for Health and Care Research Wales, and in particular, we noted improvements in the workforce metrics compliance in this team, which was really good. We received the final Head of Internal Audit opinion for 24-25 based on 24 audits that have been undertaken during the year. Pleased to say the opinion was one of reasonable assurance. We also received a number of individual audit reports, including one on mattresses, which has been assessed as a limited assurance. And we received an update on progress in terms of the 25-26 audit plan. We received an update from counter-fraud colleagues on the requirements of the Economic Crime and Corporate Transparency Act 2023 for Powys Teaching Health Board, which introduces a new corporate offence of failure to prevent fraud. The assessment is that our current counter-fraud arrangements provide good protection for us as an organisation, although there are some recommendations on training and risk assessment to consider. Finally, we received an update on the clinical audit plan for 25-26, and also we received our first monitoring report on Digital First, which follows the transfer of digital oversight to ARAC from the Finance and Performance Committee. Thank you.
Thank you, Steve. Colleagues, would anyone like to come in with a question or a contribution in response to this committee's report? No? So thank you, Steve. We go then to the Charitable Funds Committee, which I chair, and I don't have any additional comments to make. I'll take the report as read, but happy to receive any questions or comments. Does anybody want to ask anything or contribute to this report? No, so thank you. Therefore, we go to Ronnie, who is chair of our Finance and Performance Committee. Thank you, Ronnie.
Thank you, Carl. This is a short highlight report on the work of the Finance and Performance Committee, consisting of 5 pages and broken down into those items which are for alert, advise, assure and inform. I'm taking the report as tabled and read, but happy to answer any questions or any observations that others would wish to raise. Thank you.
Thank you, Ronnie. Colleagues, please do come in if you have a question to ask or an observation to make, comment to make in response to the F&P report. There are none, so we move to our People and Culture Committee, and in Simon's absence, who chaired that meeting, I think, Helen, you're going to come in and present this report. Please do.
Sorry, Carl, just had a little bit of difficulty getting off me. Yeah, thank you. Both Robert as chair and Simon as vice chair are not with us today. The last meeting of this committee was held just 2 days before the board meeting in May, so a verbal update was given at that point. So the board has already heard substantively about what was covered. This is the written report that summarises that, but I'm very happy to take any questions if anybody has any. Thank you.
But forgive me, I think I've just confused things. So I should actually have gone to Jen, who chairs People and Culture, and asked her to speak to this report. I think, Helen, you were going to speak in Simon's absence to the PPPH. So forgive me,
I've
colleagues.
just given you the PPPH one,
yeah,
Carl.
So well, I'm sorry for causing the confusion. Let's stick with PPPH whilst you're on screen, Helen. Does anyone have any questions or comments about the PPPH, which is the Planning, Partnerships and Public Health Committee? Chris, please come in.
Thank you, Chair. I was particularly noted in relation to the comments regarding the Child Wales programme and the caseload sizes that had been picked up within health visiting. I just wanted to get some further clarification regarding that, and what actions are we taking? Is there any risk to any of the families within Powys that have been affected by that, and how are we moving that forward?
Yeah, thanks so much, Chris. And the committee did receive that report in some detail, and it was an area that was identified to be followed up in the next meeting in August as well. But Claire Roach, I'm wondering if you would like to just add any comment to that.
Yeah, thank you, Helen. Thank you, Chris, for that question. We are actively doing a piece of work around that at the moment, looking at the caseloads and, of course, looking at the specific contacts that we have with children and families under the Healthy Child Wales programme. And obviously we have to report on that formally through to Welsh Government, but we're also reviewing actually how far off we are in terms of those contacts, because often with the geography in Powys, it may well be that actually the reality is that children are not seen far out of those contacts, but obviously we have to formally report in that way. So we're actively doing a piece of work at the moment looking at the Healthy Child Wales programme and the health visiting contacts as part of really a much wider workforce review within women and children's services. So the board can expect to see this on the agenda again and an update in the future.
Okay, so can I just follow that up then to say, is that then being considered within this resource realignment integrated models? And will there be details then of that being set out of what is then good practice in relation to this area?
Yes, when we come back to board and through to committee to present, to bring a follow-up on that, Chris, that will be included.
Okay, thank you.
Thank you. And so I do apologise, Jen. My eyes didn't scan properly on my on my agenda. So we will come back to you to present the People and Culture report.
Dim problem o gwbl, Carl. Delighted to be able to speak to this report. This is a part of my role which I really, really enjoy, and it's always a privilege and a pleasure actually to work with the Executive Director of People and Culture, Deb, and her team and wider colleagues as well. So you have the report in front of you. I think 3 key headlines for me which I'd like to highlight. First of all, in the workforce, we received the workforce and performance report, and we noted the improvements in variable pay data and the progress we are making towards meeting the ministerial targets relating to the use of agency staff. So we're really pleased to receive that data and see those positive trends. So that was good. Secondly, in Deb's report, Deb's always provides us, as in her role as Executive Director of People and Culture, an updated report, and we heard about the very positive and impactful measures being taken by Deb's team and again wider staff about monitoring and supporting staff well-being. Clearly a really important element of the work of the people and the culture that we want to achieve right across our health board is clearly the main focus of our committee's work. So we always are looking to understand how our people are feeling and what we're doing across the health board to continually to improve well-being, etc. So it was really good to receive some new news about the very impactful and positive measures that are being taken place. Finally, we were informed of our workforce establishment trends, and we also heard about some of the challenges around tracking some of our internal changes. But I think more importantly, we also were informed about the work being done to improve that on that tracking situation, what more we can do to improve on the tracking and the clarity of that data. So to confirm, Chair, no escalated items for the board. That meeting was the 3rd of June. Our next meeting is on the 29th of September, and colleagues and I are already working on the agenda for that and over the next couple of weeks. Thank you very much.
Thank you, Jen. So does anybody want to come in response to the People and Culture report and to Jen's introduction of the report to us? No, so a big thank you for all of that work as well. And we go now to Hayley, our Chief Executive, and to the report from the Executive Committee. Thank you, Hayley.
Thank you. So you'll see from the report that we have met 6 times up until the 16th of July, and the breadth of issues that we have covered. I'll take the majority of the report as read, but really pleased that we were able to have a very productive and positive executive to executive with shared services partnership colleagues. And I wanted to highlight that, particularly in light of the independent review that's currently being undertaken of the shared services Services partnership governance arrangements, which will, when that's available, we will report back to the board the progress on that. But I would like Claire Madsen, if that's okay, to come in, because you will note from the discussions under digital that we have discussed on several occasions the importance of taking forward the work to replace the WCIS, or the Welsh Community Care Information System, that currently we use as a health board. So Claire, just wondered if you'd like to just say a few words to give some assurance on the work we're undertaking on that. Thanks.
Thank you, Chair. Yes, my name's Claire Madsen. I'm the Executive Director of Allied Health Professionals, Healthcare Scientists and Digital. Morning, everyone. So just for clarity, WCIS is our digital patient IT system. This is where staff record information about our patient care, but also we collect data and report on data from this system. Unfortunately, this system's coming to end of life in the near future, and so we have to replace this system. This is an issue for all of us across Wales, not just Powys, and this system is used both in community healthcare and in mental health. So we are currently doing a piece of work to ensure that we can replace this system. We have looked at all the systems available and ensured that we're clear on what our need is, and we have a business case worked up. There is a national piece of work called Connecting Care that is being run centrally in Wales, and we're working closely with the Connecting Care team to look at how we're going to replace these systems going forward. And at the moment, we're just waiting for clarification on funding that will be available to the health boards across Wales so we can take this piece of work further. So that hopefully this will be clarified in the near future and we can get on with this piece of work.
You're on mute, Hayley.
Apologies, Chair. Other than that, happy to take any questions on any matters contained within the report. Thanks.
So colleagues, please do indicate if you would like to respond to or to this report, to Hayley's comments, or ask a question. Hayley, just on that point, the WCIS, because of course WCIS was a shared system with local authorities and so on, and at one of our board meetings, or feels like some time ago now, Nina did report to us that the local authority in Powys had now developed or access or developed their own system. So I just wondered, you know, what the implications of the new developments are for all system working, which we often acknowledge is so important.
Yeah, thank you. I don't know if Nina would like to come in on the decision that they've taken as an authority, but clearly interoperability is a key consideration, Carl, that has to be managed across the options that we're looking to take forward. So that is part of the work, and that's why the connected care work is looked at nationally to make sure that interoperability is part and parcel. But people have moved forward with separate arrangements and procurement arrangements. So I don't know whether, Nina, if you'd like to come in just to give some assurance on the work that's been done in Powys. Thank you.
Thank you, Chair. Thank you, Hayley. Just to confirm that in Powys Social Services, we have purchased and tendered a new system. We have now awarded that contract and are working through a transition plan to move to the new system. As Hayley alluded to there, you know, we are a part of the National Connecting Care programme, and part of that is that any system that we procure, that interoperability is absolutely key. So that we've made sure that that's a key part of the tender and award, that will still happen and be able to happen in the future. So we're in the middle of the transition plan now. A lot of data cleansing and work happening to make it a successful move onto the new system. Thank you.
That's really good to hear. Thank you both. So I can't see that anyone else wants to come in. So thank you very much, Hayley and executive colleagues, for the report. Can we just, before we move on to the next item, go back to the beginning of this paper and the summary items? And Helen, you might want to come in because I noticed, for example, that there is one escalated matter, and it says that this can be de-escalated as regards, I think, RIF, I think. So just wants to get some clarity as to, so are we now de-escalating that, and therefore that will drop off that particular log. Thank you, Helen. And any other observations you may have.
Thank you, Carl. Thank you very much. So, but just by quick introduction, paper 1.7 in the pack, as you rightly said, essentially provides the umbrella. It brings together a summary of any areas that are escalated across our committees. This is also where we keep a track for the board of what those areas are across all committees, whether they've been reported today or not. You can also see at the back end of the paper the reporting history to the board. And we developed this on the back of the revised committee reporting, the AAI reporting that we introduced in the last financial year. So that's the summary of the purpose of the paper. As you rightly said, Carl, there are 5 items that continue to be escalated to board, and often what we mean by that is that the board need to be aware of them. There isn't at this point any action that the board needs to take. If there were, that would be flagged, and we would draw that out in the recommendations. The one from performance and culture around availability of regional investment funding, at the point the committee met, that was still an unknown. Those decisions have now been made and confirmed, and therefore recommending that it's de-escalated from the board. So we weren't specifically seeking that decision from the board, Carl. We keep a track of it, and we make sure that it's reported in a timely way at each meeting.
Thank you, Helen. Helpful clarification. Colleagues, thank you. That concludes item 1.7 on our agenda, in which case we go to section 2 of our agenda, which deals with our consent agenda. And as we're aware, we do operate now a consent agenda, which means that we list under item 4 of our agenda a number of items that are not simply for information. They are there for various purposes, for assurance and so on, but we don't think that they necessarily need discussion by us, because they're not controversial, they're straightforward, and that we can therefore receive them, approve them, and note them en bloc. So you can see those items listed there under section 4 of our agenda. It's always possible for any board member to request that any item under the consent agenda be removed from that section of our agenda and placed as a substantive item on the agenda for consideration and discussion. And so does any colleague want to make such a suggestion today? Helen, would you like to come in, please?
Yeah, thank you, Carl. And with my apologies, we have an error on the agenda. 4.7, the Joint Commissioning Committee IPFR policy. That isn't included in the papers. It was on the draft agenda, but there isn't a decision or a request being made of the board today. So apologies for that error.
That's okay. We're all human, so absolutely fine. Thank you. So no one is making such a request. So we will, when we get to item 4, we will take those items en bloc, which moves us now to section 3 of our agenda, and specifically to 3.1, which is the audited accounts for 2024 and 25. I'll invite our Executive Director of Finance, Capital and Support Services, Pete, to introduce this item. And Pete, you might also want to introduce us to colleagues from Audit Wales who are also going to participate in this agenda item. Thank you.
Yeah, thank you, Carl. Good morning, everyone. So yeah, just a quick introduction from me. So this item is the Audit Wales report on their audit of our accounts, and I'll hand over to Gareth Lucy and Mike Jones just to give this update. So thanks both.
Thank you very much, Pete. Good morning, everyone, as well. Just to introduce myself, I'm Gareth Lucy. I'm the Financial Audit Director, responsible for the accounts audit here at Audit Wales at Powys Teaching Health Board. And with me today as well is Mike Jones, our Financial Audit Manager. So we're just here today to present our Audit of Accounts report. This is our standard report that we issue at the completion of every accounts audit every year. We had presented a prior version of this to the audit committee towards the end of June. That report at that time was caveated on the fact that there were a couple of pieces of work left outstanding that just needed a bit of further investigation. And unfortunately, as I'll come on to a little later in the presentation, one of those areas did require a significant amount of additional work, which has led to a bit of a delay in bringing this report to you. But I'll run through the main headlines of this report for you now. Hopefully everyone's had a chance to read through it. I won't read through all the details of the report, but just summarise the main headings for you here today. So the first main heading is in terms of our overall audit opinion. So we are proposing an unqualified opinion with regards to the truth and fairness of the financial statements, which is obviously good news. And in line with our expectations at the start of the audit, we are proposing a qualified then regularity opinion due to the Health Board's overspend against its revenue resource limit. So that was known about in advance. So fundamentally is not a surprise or anything different that's arisen from the audit, but that was an expectation before the accounts and audit got underway. Similar to that as well, we also produce a substantive report that you'll see in one of the appendixes at the back of the report there, which summarises our audit opinion, but also our substantive report that accompanies that, outlining the details for the qualification, but also outlining as well that there was a lack of an approved integrated medium-term plan for the year, and that is also a requirement, financial duty for the Health Board to be met, and so we're required to report on that at the end of the audit. But fundamentally, it's a clean opinion on the truth and fairness of the accounts, and the qualifications are as we expected going into things. Any audit finds a number of corrections. Those are set out for you in Appendix 2 of the report. There's one specific area which I'll go into in a little bit more detail now, but fundamentally, really in terms of what we've seen during the audit, the assistance we've received from the finance team, the quality of the draft accounts and the working papers that have been presented to us, there's no particular concerns that we have. Any audit always finds corrections and adjustments, and that's simply the case here as well. So really, as a whole, huge thanks go out to the finance team for their assistance as part of this work. And we have no particular concerns over the quality of the working papers and the accounts that we get presented to us. The reason for, I suppose, the delay in terms of this report coming to board today, as opposed to at the end of June, which was our initial plan, was just a particular issue that arose during the audit around continuing healthcare accruals. And you'll see further details of that on pages 85 and 86 of the board pack. Pages 8 and 9 of our report. Essentially, there was a number of issues that arose in terms of the accuracy of some of those accruals that were initially presented in the draft accounts. And as we were performing our initial audit testing, we were identifying a number of errors and areas for concern. So effectively, this has required a significant amount of work from the finance team, first of all, to go and review those figures again, and then us to come in and audit those figures subsequent to that. The conclusions of that work are included there on pages 85 and 86 of your pack. There are two uncorrected misstatements that have arisen, both not material to our audit opinion, so they don't change our overall audit view, but they do demonstrate that there was some inaccuracy in the working papers that were there. There's a recommendation for improvement that we've set out in Appendix 5 of the report as well. That's been accepted in full by management in terms of addressing processes and improving for the future. But really, fundamentally, the issue was just the delay then in the work in terms of having to carry that out and obtain adequate assurance before we're able to present this report to you here today. Something that, I'm sure Pete would say as well, but certainly from our side, we needed to make sure that we got right before we could make any sort of conclusions on this front. But ultimately, while that work has taken a significant amount of time, we've arrived at a position where we can provide an unqualified, true and fair opinion, which was the key element, really. So our work is now complete, subject to approval by the board today. The accounts will be ready to certify by the Auditor General for Wales on the 1st of August. Thanks again go to Pete and the rest of the finance team as well for all their efforts, just in terms of the audit as a whole, but also in response to this particular issue. We appreciate it's never particularly comfortable or easy having to to slot in quite a significant amount of additional work. So we really appreciate the efforts they've gone to there on our behalf and the assistance they've provided. And other than that, Chair, happy to take any questions that anyone has.
Thank you, Gareth. Pete, do you have any additional comments before we open it for discussion?
Yeah, just to say, Carl, yeah, thanks, Gareth, thanks, Mike, and to Ali and the wider team. As Gareth's identified, we did come across an issue. I just want to thank the audit team in the way that this was approached, the way that we worked through it, the clarity on what was needed, and then that sort of joint working to get things concluded. So yeah, my thanks to Gareth, Mike, and the wider team.
Thank you, Pete, thank you all. I mean, clearly, the delay is not ideal. It's not, however, as you say, Pete, it's good to know that the response to finding those issues was constructive, and certainly that processes are in place now to learn from that and to change things for the future. So that's really assuring. Steve Elliott, I know that we're going to come on in a moment or two, Steve, to the report from your committee and to its formal recommendation. But I just wondered whether you wanted to pass a comment about the auditor's report from your perspective as chair of that committee.
Well, I was actually going to cover that in
Okay.
my recommendation. So if we could hold off for a sec, that'd be fine. Thanks, Carl.
Yep, absolutely fine. Colleagues, does anybody else want to come in relation to the Audit Wales Audit of Accounts report? No? So a big thank you, Gareth, Mike, really good to know and to hear, as we do actually repeatedly, of the constructive, positive working relationship between ourselves and yourselves. So a big thank you for that. Board colleagues, we're asked to receive the Audit of Accounts report 2024-25. Please indicate if you're not content to receive the report. That therefore is received unanimously, in which case we do now turn to Steve and to the recommendation from the Audit Risk and Assurance Committee in respect of both the report and the accounts. Thank you, Steve.
Thank you, Chair. So yes, as previously highlighted, the ARAC has considered the progress on finalising the accounts at its meetings in May, June and July, and we were kept informed by Audit Wales colleagues on the position regarding the additional testing required on CHC accruals following the errors found during the course of the audit. At the meeting in July, the committee did express its disappointment that the errors and the subsequent testing required had led to the Health Board missing the Welsh Government deadline for submission of the annual accounts. And so the committee has asked for a full lessons learned paper on this issue to be presented to its next meeting in October to give assurance to the board. There was just one other issue to bring to the board's attention in the accounts, which is due to the late invoice received from Wye Valley Trust for £5 million. As this invoice is still a subject to an ongoing dispute which has been escalated to Welsh Government, it has been treated in the accounts as a contingent liability, so no charge has been made to the accounts, and Audit Wales have accepted that treatment. As Gareth mentioned, because the Health Board has been unable for the third year in succession to balance its books, the Auditor General is qualifying his regularity opinion on the accounts. So cumulatively, the board has overspent by just under 35 million over the past 3 years. So obviously, that's not a great position to be in, but is, as Gareth outlined, it was known prior to the start of the audit. But these issues aside, subject to the letter of representation being received, as Gareth outlines, the AGW intends to issue a clean, true and fair view audit opinion on the accounts. And therefore, ARAC is able to recommend that the board approves the annual report and accounts, letter of representation is issued, and that the board authorises the accounts to be signed where appropriate. And finally, the committee just wanted to acknowledge all the hard work that goes on across the organisation. It goes into the production of these accounts and the reports. and also to thank colleagues from Audit Wales for conducting the audit in an efficient manner. Thank you. Happy to take any questions.
Thank you, Steve. Colleagues, any questions, any contributions? Hayley, please come in.
Yeah, thank you. And thank you, Steve, for the update. I just wanted to comment really as accountable officer, missing the deadline at the end of June is really not ideal, but really important that the additional work on the CHC accruals was completed, and I'm really keen for colleagues to be aware that we have kept Welsh Government updated at every stage on the progress and the work that's been undertaken in partnership between the finance team and Audit Wales to get us to the position today for approval. I think the point that Steve raised around lessons learned and the period of reflection that will take place as usual in partnership with Audit Wales will be important for us to come back to the next Audit Risk and Assurance Committee, and I know there'll be substantial work undertaken to make sure that we can address the recommendation, and just again, as Audit Wales said, we have accepted that recommendation in full. And then I think the final point to say is that, you know, the way in which Audit Wales have worked with the finance team in response to this and the substantial work undertaken by all parties, incredibly grateful for all their work and efforts. Thank you.
Thank you, Hayley. So I'll just pause slightly should anyone else want to contribute to this agenda item. It doesn't seem like anyone does. So I mentioned earlier how very, very important our committees are in being a source of assurance to us as a board. The Audit and Risk Committee is a very key committee. It's a committee that in many ways keeps us safe as an organisation, and therefore its recommendations are very, very significant. And therefore there isn't that the purpose of this paper is that we receive its recommendation to approve the report and the annual accountability report and the financial statements, and to approve the letter of representation and to authorise the Chair, Chief Executive, Director of Finance to sign them when required. So we receive that recommendation, and we will go on now under item 3.3 of the agenda to consider the annual report and accounts. And we're back to you, Pete, for this item, and I think you'll bring in other colleagues as and when required. Thank you.
Yeah, thanks, Carl. So really the plan is not to go through the whole annual report, the annual accounts and the relevant a letter of representation, etc. in detail. They are included in full in the board papers. They're there really for that full information, and as Steve has already outlined from the Audit and Risk Committee, the recommendation that they're approved and supported. So wasn't going to go through in detail, Carl, but we can open up to any questions or comments as needed. But the recommendation is to approve the annual report and accounts and the letter of representation for signing. Thank you.
Thank you. So once again, colleagues, a very long report, but a very important annual report. So please do indicate if you would like to ask any question or make any comment on the annual report and accounts. So we'll go firstly to Helen, please. Helen.
Thank you ever so much, Carl. Just to very briefly add, as Gareth outlined, the Auditor General for Wales is due to sign these accounts on Friday this week, the 1st of August, assuming that the board is content to approve them today. That will be then submitted to Welsh Government and published onto our website. Given that we've had a slight delay in the audit work, we've had to reschedule our annual general meeting, and that is currently set to be held on the 15th of September. So assuming the board's agreement and support today, we will then undertake the actions to make sure that that's put in place. If I may, Carl. Like Steve and Pete, I'd just like to add my thanks. The annual accountability and performance report has come together incredibly smoothly this year, and I'd like to just pay particular tribute to our performance team, estates, people and culture, finance and the corporate governance team, and just particular thanks to Liz Patterson, who in my team has brought all of this together very efficiently and very professionally. Thank you.
Yes, and Sonny, I'd want to support that and echo that, Helen. Thank you. Jen, please come in.
Yes, yes, indeed. I also wanted to commend the report. It's vast, but I really appreciate the way that it's been structured, and I think it gives a very accurate, realistic, pragmatic, candid assessment of our performance last year. And I just got a question really in terms of the narrative section, and probably one for you, Hayley, really, which is on page 22, you give this really helpful end of year summary record of how we performed against the various measures, I think outlined in the NHS performance framework, and we've got 25 measures where we have delivered or they're on track, and I think we need to celebrate that. We all know the challenges that we're all facing, so I just want to offer my sort of congratulations and really well done to the team, to everybody right across this board for achieving those measures. That's great, but I also really like the fact that you've been very clear about where we've not yet met the targets, and those issues and areas that we need to do more work on, etc. So my question is just around about that latter section. How are we making sure that we are keeping green on all the things that we have already achieved, and how are we, what is the mechanisms within across your executive structures which allow us to be able to keep track on where we are? We have yet to achieve those targets, and how we can make sure we can improve on that performance this year. So just a headline about that, I'd appreciate, Hayley. Thank you.
Thank you, Jen. It's a really important question, and I always find in an annual report we're retrospectively looking at the past rather than actually giving assurance on what we're doing in this year as well. But I mean, I think I draw attention to, in terms of our board reporting, our integrated performance report is absolutely critical to, at a public board meeting, to give assurance on the progress that we're making. But in terms of the plan that we set performance trajectories at the beginning of the year to further improve or to maintain performance across a number of key areas. We receive substantial reports through to the executive team on the basis of the integrated quality and performance framework process that we've got, and we get that regularly through the progress against all of the measures. So we're able to track, are we maintaining, are we improving, and most importantly, are we actually hitting the trajectory that we set at the beginning of the financial year? And then that goes through to the relevant committee, Finance and Performance Committee, in particular, receive assurance across all of the measures. But then clearly there's a focus in patient experience around quality and safety, and then with yourself, the workforce KPIs as well. So I think we've got a really quite a thorough approach to actually track the performance that we've got in the year. And clearly, by exception, then we bring that through to both the relevant committee and to board. So I hope that gives you some assurance that our plans against continuously moving forward with those performance KPIs that we are set against is really quite custom and practice, and we've got quite strengthened reporting. And clearly we also had the reasonable assurance, was it reasonable? I'm trying to remember now. I'm looking to Nick. I'm pretty sure it was reasonable assurance on our performance arrangements in tracking that as an organisation. So we'll continue to build and use those mechanisms in year. that okay, Jen?
Yeah, that's really reassuring. And I sort of did know that, but it's really good to be reminded, particularly of how each of these issues are joined up and how there's a sort of a seamless transition from an issue which needs to be addressed and how there is that golden thread or where that issue is not lost and it is picked up by the relevant team at the relevant place and then goes through the assurance process. So thank you for reminding me about that, Hayley. I really appreciate that. Thank you.
Thanks.
Important. Thank you, Jen. And so I can't see that anyone else wants to contribute. So we will move to the recommendation, and that is that we approve the annual report and accounts for 24-25 for signing in readiness for submission to Audit Wales and Welsh Government. And that we also approve the letter of representation for signing by the Chair and Chief Executive on behalf of the board. So once again, if you are not content to support that recommendation, would you please indicate? That too is supported unanimously. So we're running a little bit ahead of time, which is not a bad thing at all. So I think we will take our break now. We will take just under 15 minutes, and I'm going to suggest that we reconvene, please, at 11:10. Thank you. Wel, croeso nôl i'r cyfarfod ar ôl yr egwyl ac dyn ni'n ailgydio yn ein hagenda drwy ffocysu ar eitem 3.4. Welcome back to our meeting. We take up our agenda at item 3.4, which draws our attention to our annual plan for 2025 and 26. Just by way of introduction, it's probably worth just highlighting that as a board, we have spent and we continue to spend a considerable amount of time considering our plan for this year and the complex and various challenges associated with the plan. As a board, we are absolutely committed to ensuring we deliver the highest quality of services that are timely, financially sustainable, and that are compassionate for the people of Powys. And we do so as we navigate the sometimes tricky terrain of balancing the legal and the statutory duties placed upon us. And so we're not here today to consider a different plan or to change the plan in any way, but we are here today to receive an update as to where we are in that planning process. And so I'll invite our Chief Executive and the Executive Director of Planning, Performance and Commissioning to initially speak to this item. So Hayley and Nicola, over to yourselves, please.
Yeah, thank you, Chair. Also, Pete, our Director of Finance, will come in on a couple of slides in the presentation as well. So, as you've highlighted, this presentation, which hopefully will be shared in a minute, can't see the slides are up yet. Just checking that they're up. Yeah, okay, great. So yes, this presentation provides the board with an update since our approval of our annual plan for 25-26 in March, of our ongoing dialogue with Welsh Government. We will also be providing an overview of our assessment of our current annual plan against the Ministerial Advisory Group recommendations, which were published in April after we had submitted our plan in March. So it would be very important for us to cover that. So if we go to the next slide, if that's okay, please, Liz. Thank you. So just to remind the board, back in March, we approved and submitted to Welsh Government our annual plan. And at the time of that submission, the forecast position referenced 38.4 million, and we identified additional actions that we would continue to pursue and discuss with a range of providers to improve our position to deliver a potential of 16 million. So at that time, this required the organisation to deliver £11 million savings, and that's equivalent to 3% of our funding. During April and May, we have had correspondence from Welsh Government telling us that this position is unsupportable and unacceptable, and the expectation and reminder that the board was set a target control total of reaching 12 million. We submitted in May then further to the additional work during April and May to Welsh Government, resetting the financial forecast from the original 38.4 to 28.3 million. And to give you context, this requires the Health Board to save 23.1 million, which is equivalent to 6.3% of our funding. Next slide, please. During June and July, we have continued to be in dialogue, and Welsh Government have confirmed that they want us to improve further our financial forecast to maintain our outturn of 15.8 million deficit. And the scale of this would mean that we would require finding an additional savings of 12.5 million, making the in-year ask 35.6 million savings, or equivalent to 9.7% of our funding. I wrote an accountable officer letter at the end of June, stating that at that point we maintain our £28.3 million forecast, and that we're again looking at further options to further improve from that, and we'll take you through those options in later slides, but specifically additional actions that the board discussed in our board development session and in committee session during June. We have had a meeting, the chair, or the vice chair and myself, during Carl's leave, attended a meeting alongside other health boards with Welsh Government to discuss the latest position, and there will be an expectation further to conversations taking place today that we set out our response to the latest ask, which is what would it take to deliver last year's outcome position of 15.8 million and send that back to Welsh Government tomorrow. I know that the chair at the start of the meeting in his report referenced the fact that during the last tripartite discussions where the escalation status of all health boards were discussed, that our position in Powys is that we have maintained our position at level 4 escalation for strategy, planning and finance. But these are the fine balances we've been trying to manage. We have successfully stayed in routine monitoring for all other domains of the escalation framework, and that is a credit to the focus of the organisation in continuing to deliver the performance and outcomes requirements, and particularly against the quality requirements during this time. Next slide, please. If that's okay, Liz. Thank you. So some of the context for decisions that we've taken to date, both in setting our March annual plan, but also in the ongoing discussions and consideration of what more could and should be done, is that, as the chair outlined at the outset, I know that this board and myself as accountable officer take really seriously our responsibilities with regard to meeting our statutory financial duty, financial governance and management. And it's that balance and need to plan and deliver services within available resources, alongside the balancing of our requirements around the duty of quality and candour, the equality duty, and also making sure that we stay the right side and deliver against all domains of the escalation framework are the sort of considered points that we need to discuss. And, you know, some of those domains are broader than just our performance and outcomes. Quality of care is really important, but also our governance, leadership, capability and culture is also something that is looked at very carefully through those assessment meetings that take place between Welsh Government and the regulators. The other issue to raise is clearly we are in an annual planning cycle currently, needing to set annual plans due to our escalation status at level 4. But we've also got to set progress for the medium to long term. And in particular, we referenced, and later we'll be covering Better Together, and the need for us to develop options for the future that brings us back towards financial balance as quickly as possible. So I'd like to ask now Pete Hopgood, our Director of Finance, just to give an overview of the position. Thanks.
Yeah, thanks, Hayley. So this table really is a summary of all the actions and the details that Hayley's just taken us through. So what it does, if we start on the left-hand side in the first left-hand column with numbers in it, it gives our financial plan starting point, which was 38.4 million. That 38.4 million included the £11 million of a savings target that Hayley has just highlighted. It includes our emerging additional cost pressure in relation to our increased activity and spend with our private providers in relation to mental health provision, and then the further actions that were previously been approved by the board, One of those including actions to mitigate that increased cost in relation to private providers, and then action to secure additional funding in relation to our delays around length of stay. The action we've taken in relation to our NHS England activity targets, a further requirement around our joint commissioning committee to deliver within the funding available, and then ongoing action as already referenced in relation to length of stay. Those areas of potential improvement on our original starting point are included on the table on the left. If we move across to the right hand side, the furthest column with numbers in, that gives an assessment of the current actions in those areas and the likely financial delivery, which makes up the basis of our current financial plan forecast of 28.3 million. Excuse me. Also included is a scheme categorisation rating, being green, amber or red, just to highlight the Joint Commissioning Committee currently has a forecast overspend, hence the RAG rating of red. Also included in the table underneath are those further actions that have recently been approved by the board. They are an additional 2% target for all areas that could deliver a potential of up to 7 million. At the moment, there's been a lot of action and work in these areas, but there's not a level of confidence that will give us delivery above our current plan of 28.3. Also included is a further work looking at our NHS England outpatient activity. So in summary, the table highlights the starting point of our plan, the further action areas the board has approved to take action in, the current assessment of the likely delivery in those areas, and our current forecast position of 28.3. If we move on to the next slide. This next slide is a summary level of all of the savings and efficiency action plans that we have. As was referenced earlier by Hayley, we have a total savings target of just over 23 million. That's at the bottom line in the first column's numbers figure column. Against that 23 million, just to say these are the summary headline sort of areas of the plans. Underneath this, there are circa 100 individual action plans delivering against these targets. Against the 23 million as at month 3 reporting, we've identified 17.3 million pounds worth of green and amber schemes, with the current shortfall to meet the target of 5.7 million. I can update though that further action has been taken in relation to improvement in relation to pathway care delays, last length of stay, and in relation to some action in our women and family health area. That's given us another 0.9 million pounds worth of green and amber schemes, given our total current green and amber rating of 18.266 million against a 23 million pounds target. And just to apologise, I also have a bit of a cough and cold, so my voice is a little strange today, so apologies from that. And we can move on to the next slide, please.
Thanks, Pete. So I'm taking this one. So in terms of the progress update on Commissioner elective care in NHS England, the board made the decision in the public board in March to commission elective activity in NHS England in line with the NHS Wales performance framework. And as agreed in that meeting, detailed negotiations have proceeded with the providers. It is worth noting again that this change excluded urgent and cancer patients and patients under the age of 18. In line with our commission intentions, which we published to the providers, Wye Valley NHS Trust and Robert Jones Agnes Hunt Orthopaedics Hospital operationalised the change for elective treatments from the 1st of July, and we continue our discussions with them around outpatients. As reported to the board on a regular basis, there have been data reporting issues with Shrewsbury and Telford Hospitals NHS Trust, which are resolving, although they continue to a degree. However, progress has been made on agreeing the contract and baselines for 25-26. The Trust has not yet confirmed that the elective change for either treatments or outpatients has been operationalised from the 1st of July, and we continue our formal negotiations with the provider, noting that there is an increasing risk of escalation. The current financial assessment of this action remains at around £6 million to the Health Board in year against the target that Pete described in previous slides. However, the deliverability assessment notes the increasing risk regarding SAF. The quality impacts are being tracked and will be reported on a quarterly basis for the remainder of this financial year to the Executive Committee and thereby to the PECs. As of this week, there have been no urgent incidents raised relating to this change and no urgent concerns. So if we can have the next slide, please. So in terms of additional improvement, on the 25th of June, the in-committee board approved the following further actions to be developed in detail and at pace. So the continued work to defer outpatient appointments in NHS England. And as I've just outlined, those discussions and negotiations continue with the providers. But also to increase the internal savings target by a further 2%, as Hayley outlined on the slide at the top of the presentation. That takes us to nearly 6% savings across all areas in total, with elements being maximising efficiency in terms of cross-cutting schemes. If you're wondering what the SWAT team is, it's an acronym that's used in the American police, but in sort of management terms, organisations use it in these sort of circumstances to describe an urgent response team looking at efficiency across the health board, and that's the way that we're using it. In future presentations, we'll describe it as the Business Efficiencies Urgent Response Team. In terms of pay controls, things that we have considered before, but taking them to the next level, and new things that we haven't considered before, such as voluntary early release and working through those options. We're also undertaking structured SLA and other contractual reviews. Again, for the first time with this additional savings target, those will be applied to the third sector, or we're assessing the ability to apply that to the third sector and to primary care. And we will be undertaking an evaluation of all the investments that we've made over the last number of years and doing a structured review to see if there's areas that those benefits are not transpiring, in which case review will suggest to disinvest, reinvest, stop, or obviously continue if the benefits are occurring. And in terms of prescribing a further opportunity, if somebody can remove that additional screen, that would be helpful.
Liz, we've just got an additional screen on the live stream. Be able just to remove that? Apologies, Nick.
That's fine. I haven't memorised every sentence, but I'll carry on. So for prescribing the further opportunities above the current savings plan have been identified and are being assessed as we speak. There are additional risks that have been identified since we last discussed this with the board. On a national basis, there are a number of financial risks that we will need to manage and mitigate. These apply to all health boards, and we're in close discussion with Welsh Government about the handling of those. As can be expected with this additional work, executive leads are assessing the impact on the delivery of our existing annual plan actions, and that will be reported as part of our usual cycle in the Q1 delivery plan report. And again, extremely important for us, but we again acknowledge all this additional work, plus that we're running at pace in the Better Together programme, but really important for us as a health board to ensure that the Better Together programme continues as planned. Next slide, please. Hand back to Hayley.
Thank you, Nick. So in this first part of this presentation, the recommendations to the board is to be fully aware of the ongoing dialogue with Welsh Government and the requirement to us to respond again to outline what it would take to get to last year's outturn position of 15.8 million. The work, it's been very detailed negotiations and discussions with our providers to with regard to the decision that we took around commissioning. And I think it should be noted, you will have seen earlier in my CEO report the reference to the petitions, the Senedd petitions regarding this decision, and also that the Powys County Council did agree a motion regarding Powys patients attending English hospitals at that time. But you know, the board needs to be taking assurance that we are continuing to implement the board's decision in March through negotiations with our commissioning partners in NHS England, and also that you are aware of the additional action that we have agreed to add additional 2% savings targets across the health board, which has resulted in our ability to respond to the latest correspondence from Welsh Government. We'll move on now, if that's okay, just for Nick to give an overview of to what extent we feel we are meeting the Ministerial Advisory Group recommendations in the current plan that we agreed back in March.
Thanks, Hayley. We've undertaken an assessment of the MAG report against our agreed annual plan, and these slides assess, as Hayley said, that report on that assessment. So just a reminder that the Ministerial Advisory Group, known as the MAG, was established last October by the Cabinet Secretary to carry out an independent review on NHS Wales performance and productivity, to provide with a remit to provide those assurances and observations that are outlined on the slide. It reported formally on the 31st of March and was published in April and is available in the public domain. Welsh Government also responded, and that was published alongside the final reports. We have assessed both of those reports against our annual plan to identify areas of alignment or gaps in those actions or measures which are for health boards to deliver, noting that there are many actions and measures in the MAG report that are not for health boards to deliver, they're for other parts of the system to deliver. We've also assessed it against the original requirements in the NHS Wales planning framework for 25-28, which is what our annual plan responded to. And then the priorities contained in the Cabinet Secretary speech of the 7th of April, which was obviously after we'd approved the annual plan. It is worth saying that on the 3rd of July, the Cabinet Secretary wrote out to all health boards outlining the way that the recommendations of the Ministerial Advisory Group on performance and productivity, known as the MAG, the planning framework, the report on the accountability review, and the Cabinet Secretary priorities would be brought together by Welsh Government in one process going forward, known as improving performance together. So this assessment that we've done against those three elements was very much in line clearly with how the Cabinet Secretary was thinking. Next slide, please. So this is the overview of the MAG report, just in summary, and you can see that particularly in planned care, many of the actions for health boards and in urgent emergency care, but in many of the other domains, they are for Welsh Government or other national bodies. So just noting that. Next slide, please. And this is the comparison that we've undertaken with the planning framework and Cabinet Secretary priorities. Next slide, please. And again, mapping those commonalities, which obviously Welsh Government have brought together at a national basis in that improvement together, performance together framework. So the important bit is our alignment to our annual plan. So generally there is alignment to our annual plan because much of what was in the MAG was aligned to the planning framework. And this slide outlines in red where there is alignment, but there is a difference in timescale. So members may well, if they're very familiar with the MAG report, will know that the timescales were very ambitious, with many things due to be delivered in 3 to 6 months. Which obviously in our annual plan, we may have taken longer in those things. But in general, all of the areas, particularly around plan care, are included in our annual plan. There is a difference with regard to pathology, and that's because we don't deliver that as a provider. And the planned care measures, the key planned care measures remain as would be expected, but also include the overall reduction of the waiting list by 200,000 patients, which we will report on during through our IQPR going forward, our part of that. And in relation to urgent emergency care, again, the main difference is around timescale. The measures are around ambulance handover and discharge to assess delayed pathways of care. So again, we generally report on those measures through our IQPR, but we are assessing that we've got our data on the delayed pathways of care to see if we can include that in our IQPR going forward as well. Obviously, with ambulance handovers, we're not a provider of those services in terms of A&E, but we do report on those through the IQPR in terms of our commission services. Next slide, please. And one of the other areas just to keep an eye on is around regional planning and delivery, which obviously we are involved in much of this through the regional arrangements, and some of that again will be formalised further with the when the formal committee for South East Wales is stood up. Next slide, please. So very importantly for the board in terms of monitoring reporting, to understand that at national level there will be monthly CEO level monitoring meetings around all of those measures in that improving performance together framework. That internally progress on the actions of the MAG that don't have measures as such will be tracked and reported quarterly via the annual plan delivery plan reports. And we will highlight those in those reports. And the measures generally are already included in our IQPR with those couple of additions which I've outlined. However, we will need to think about an overall report coming through Finance and Performance Committee, and we'll discuss that with the chair of that committee in terms of the timeliness of that. Next slide, please. The rest of the pack is for information in terms of the full MAG recommendations, Chair, so happy to stop presenting at this point.
Thank you. Hayley, is there anything from you before we open up the discussion? And
no,
okay.
I know there was a lot in the content there, but I think it's really important that we went through that detail, and in particular with regard to the Ministerial Advisory Group recommendations, there's substantial focus on this going forward. And just for awareness, there have already been 3 meetings, CEO level meetings regarding this that I've attended, and that will continue to take place on a monthly basis. So nothing more from us, Carl, just happy to answer any questions.
Thank you all. And so, colleagues, please indicate if you'd like to contribute to this agenda item. So we'll go firstly to Steve Elliott.
Thank you, Hayley and colleagues for that. Hayley, I just wonder if you could just say a few things about how the additional 2% savings target has been received within the organisation, because obviously that's quite a significant ask on top of what was already expected as part of the original plan. So just how has that been received, and are there schemes coming forward to deliver against that? Thank you.
Thank you, Steve. I think that you know, the view generally is this is incredibly challenging, but I think there's a recognition that, you know, further financial improvement is something that we have got to deliver. I think we've recently communicated out some of the changes, in particular around the workforce matters, out to the organisation, and also we've had some discussions in the partnership forum with staff side partners as well. So I think the severity of the financial situation that we're facing, the need for financial improvement and action is something that colleagues appreciate and understand, but also it causes some concern. absolutely, in the wider organisation around both the impact and also the capacity to deliver the additional actions that we require in order to make that further improvement. We're still working through the detail of some of that, and I think we've got some more granularity and discussions needed across the organisation in a couple of key areas. But for example, the discussions that we've had have also been generated by some of the teams. So the example of prescribing, some of the suggestions that we've included has actually been based on the analysis that the teams have undertaken. So it's a mixed picture, Steve, but I think the general understanding of the need to undertake work to provide further financial improvement is something that people are understanding.
And Deb, I wonder if you might want to come in and offer a workforce perspective in response to Steve.
Yeah, thank you. Hopefully colleagues will have seen a note that was circulated last week, which is probably working its way through on a cascade basis to all of our employees. I'm sure our employees will have noted a stronger tone in there, and being more directive about what we can and can't do now across a range of areas such as training, external room hire, reducing travel, etc. So I don't doubt that it will start to feel different to our teams. And for the first time, even though we've had a voluntary early release scheme in place, we haven't been promoting that to our employees. There's a lot of support around. I'm really grateful to trade union partners for the work that they do with staff, but my teams are out and about, both helping with the understanding of the messages, listening to any kind of local questions and supporting, or at least signposting through to the various wellbeing kind of support tools and platforms that we've got in place. So we'll need to keep an eye on that, and we'll need to keep an eye on countermeasures such as like increases in sickness, because of course that doesn't help us either. So very early days in terms of monitoring the impact of these additional measures, but I'm sure we'll report back that at future board meetings. Thank you.
Thank you. You content, Steve?
Yes, thank you.
Okay, so we go to Kirsty, please.
Thank you very much. Nicola, thank you for outlining the MAG recommendations. It is really important that we track our plan. Whilst there is general alignment, there are issues around some timings. So having done that analysis, will we amend any of our programme for the year, or actually is that not possible? So I'm interested in, having done the analysis, will anything change first? And then with regards to commissioning arrangements with NHSE, in the presentation, it said that we would be monitoring quality impact, and that would be reported through to both Exec and PECS committee. Could you give some further details on the metrics that will be used and how we will monitor the quality impact of that decision, please, so that we have some assurance that that will be done in a really rigorous way and we'll be able to act accordingly. Thank you.
Thanks, Kirsty. In terms of changing timings, we are considering that, so we report on that in the Q1 report. In terms of quality metrics, I'll bring Claire in just to sort of give a rounded view on that, but we are tracking that through the Quality Oversight and Assurance Group as lays out in the refreshed IQPF, and then that will inform those reports to Exec and PEC. So we've got those assurance mechanisms in place, but I'll bring Claire in on the rounded metrics.
Yeah, so thank you, Kirsty, for that question. And I'll try and keep this answer brief because it is actually quite complex. So I think there's a couple of things here. The first is that in terms of our quality impact assessment, we are undertaking and have undertaken quality impact assessments which take account of the domains of quality in terms of timeliness, effectiveness, safety, efficiency and person-centeredness. So it is really important that we absolutely address and make that assessment under the domains of STEEP. And then in terms of obviously ensuring that we are quality monitoring any decisions that we make and any actions that we take, we will obviously monitor that through our triangulated approach in terms of concerns, complaints, patient experience and feedback, monitoring incidents, and indeed monitoring any positive compliments that may come into the service. So I think it's really important that actually we maintain our existing structures for our quality assurance and quality monitoring in line with our integrated quality performance framework and the way in which we deploy our quality management system.
Thank you. Do you want to come back on anything, Kirsty, or you? No?
No, thank you.
Okay, thank you. We go now to Ronnie.
Thank you. I have a specific question on Shrewsbury and Telford, but before that, I'd just like to acknowledge the amount of work that's gone into that presentation. It has been substantial. In relation to Shrewsbury and Telford, I wondered when we think we're going to be fully on top of the data reporting issues. Do we have any clarity on that? And then no elective change from the 1st of July. We're now at the end of July. I just wondered what the sense was of making progress on that and the degree of urgency that now sits around it. Thank you.
Thanks, Ronnie. The data issues remain. They are improving. We don't have an end date, but we would expect those to improve through Q3 and hopefully to be resolved by the end of this calendar year. In terms of the response from Shrewsbury and Telford, I think we remain in discussion with them. From our point of view, it is urgent, and obviously we remain in conversation very closely with the provider on that basis, but including sort of level meetings both at director level and at chief executive level.
Chair, could I just add to that? So Ronnie, next week, the movement now to chief executive meeting is taking place next week, because the timeliness of our ability to bring to a conclusion the negotiation is critical. So after that meeting, we'll be able to provide a further update to the board.
Thank you, Haley. That's the assurance I was seeking.
Thank you. Mick, would you like to come in, please?
Yeah, thanks, Chair. Again, just, as everybody else, just, kind of acknowledge the amount of work that's going on in the background and the extent to which members have been involved in those conversations, and therefore, have confidence in and support the proposals that have been put forward. But I'm just very conscious that, whilst government's position in terms of their requirement to achieve, the 15.8 million control total was pretty unequivocal. And, even if everything that we're currently considering delivers in full, there's still a shortfall. And, I calculated around about 5.7 million. I may be wrong there, and Pete will no doubt correct me. But hopefully, whilst government will recognise, just how far the board has gone to drive out costs, 9.3% is hugely significant. And as I understand it, that's way beyond what the health board's been asked to achieve. But if not, and we have to address that shortfall, I'd just like some reassurance that we're starting to think through the unpalatable, where we might go next if that shortfall hasn't been closed down and remains to be closed down. I'm not looking for specific proposals. I'm just looking for some reassurance that we're starting to think that through, because, last year, based on last year's experience, we learned how difficult it was the closer you get to year end to drive out anything which is meaningful or achievable in terms of driving costs. So not looking for proposals, not looking for suggestions, just some reassurance that we're starting to think about the unpalatable.
You're on mute, Hayley.
Sorry, I've done that twice. Apologies, Mick. Absolutely. So we two things to say, that we have got to answer the question to Welsh Government around what it would take to close that gap towards 15.8. And we're already in unpalatable decisions, in my opinion, because of decisions we've had already taken in March in terms of the decision around commissioning, etc. So I think we're already, and we've just discussed the 2% issue and the reaction of the organisation to that. So we are already transacting unpalatable options that are difficult to implement and negotiate. But yes, we will be looking at those options. I think the other issue to note is that we are going through the final stages of confirming some additional independent support and review of our financial position as the result of the level 4 escalation we've been placed into by Welsh Government for finance strategy and planning. That work will hopefully start in the next few weeks, well, certainly during August, and from that work, that will be really important for the board to take assurance on stress testing, what we've done to date, and whether there are other opportunities that could and should be identified for our consideration. But clearly the timescale point that you raised, Mick, is an important one. The longer we go into the financial year, the reduced opportunity there is to further improve the situation. So I just wanted to give assurance to the board that on both counts, unpalatable options and also additional external assessment of whether there are further opportunities for us will come back as quickly as that work is complete.
Okay, thank you. Thank you all for the contributions. Let's move now to the recommendation in relation to this item, and that's that we note the correspondence from Welsh Government and the requirement to send additional accountable officer letter on by the 31st of July, that we take assurance that the organisation continues to work towards implementing the board's March 25 decision regarding commissioning in NHS England. We note the approval when we met in committee on the 25th of June to apply an additional 2% savings target across the health board. And we also note the assessment of the Ministerial Advisory Group and the application to the Health Board's annual plan and arrangements for monitoring and reporting. Would you please indicate if you do not support that recommendation or any part of it? That is supported unanimously. Thank you. So that takes us to item 3.5 of the agenda. We have been discussing our annual plan, and as we often remind ourselves as a board, what is absolutely crucial is our longer term planning and our route map to sustainability. And the Better Together programme, our transformation programme, is a very, very important and key element within that. And certainly what we're trying to do is to make sure that we don't make any decisions now that impede or undermine our ability to transform things in a way that is needful into the future. And certainly we do so recognising that we align our planning with Health Board strategy, with national policy, with legal duties, including, importantly, the duty of quality. So this agenda item today provides us with assurance about where we are in that Better Together journey, and specifically around the delivery of stage 2 of the engagement approach during this first chapter of Better Together. And so, Deb, I'm going to invite you to come in and to present this item and to share the update. Thank you.
Thank you, Chair. So there are slides in the board papers to support this item. I'm not going to go through them individually, but kind of echo all that the Chair has just said about just how critical this programme is to us, and therefore on a regular basis checking that we are protecting the capacity so that we don't interrupt the programme's momentum. As said, this update is mainly focusing on the stage 2 engagement activities as part of the programme, and now that they've started to come to an end, a report is being summarised, setting out all that we've heard at the events and more broadly, and will be received at a future public board. The events in themselves enable very deep discussions on the scenarios and hurdle criteria, as you'll see in the slides. And these events were in addition to wider activities where the team have been out and about across the county, visits to local community groups, focus group events and drop-ins, and at sites talking to over 400 staff. And we also have regular 3-figure attendance at the chief exec staff briefing. So doing all that we can to test and hear from kind of staff stakeholders and the public. Just a bit more broadly, I'll just bring us up to date on where we are with the programme more generally. Week commenced on the 14th of July. We held a lock-in week to test the long list of ideas emerging from the discussions with public, staff and stakeholders. And those emerging ideas were then tested out by clinical, operational and corporate teams to start to hone down to a number of shortlisted options. All of that is now being taken through to the next stage of design work. Just to help with our journey and test any emerging model options, we've recently engaged external clinical subject matter experts to test and challenge us, and also appointed independent facilitators who supported those stage 2 engagement events. The process is also underway for procuring additional resources to support consultation and assurance, and if needs be, Helen may want to comment on that. So in summary, whilst the programme is not without its risks, we are making good progress, taking all opportunities to listen to our local voices, and are on track against our accelerated timetable, and we have a critical path from where we are to consultation. And that's all I was going to say on it, Chair, but happy to take any questions or reflections. Thank you.
Thank you, Deb. And I know that independent members have been engaging with and observing and listening to some of the engagement meetings and forums and so on. So thank you for that update. Colleagues, do come in if you have a question or a contribution to make. So we'll go to Kirsty, please.
Thank you, Chair, and thank you to Deb and all colleagues that have been engaged in this work. Deb, you gave some figures around staff engagement, which are really impressive, the level of engagement that we're having with staff. And I know a huge amount of effort has gone into those community events and the drop-ins. How do we feel about the level of participation that those events have been able to generate from members of the public? And when we hear from members of the public, are we satisfied that we are having across, a really diverse level of engagement with our communities? And if we're not satisfied, because we've made great efforts, but sometimes that doesn't deliver what we would have hoped and what we would have wanted, how will we take those lessons learned into the next part of our engagement? Thank you.
Thank you. Just to come back on that, I think the stage 2 report when we have it, we'll put all of those events, all of those numbers, all that we heard into one place. And I think, you know, whilst we might have had reflections along the journey, I think it does allow us to just pause and reflect about what that tells us that we need to do for our future activities. Whilst the events, particularly some of the evening drop-in events, were small in number, they were rich in conversation. So I wouldn't want to kind of belittle any of the kind of stories that people were describing and their familiarity with kind of where we were, and actually some were also talking back to the strategy and involvement in that at some future place. There is a variety, I would say, of understanding and awareness, and I think that's why it's important that we keep that dialogue up, not just through the formal Better Together events, but through our general events and conversations with the public. The one thing I didn't say was that, and this might not be totally up to date now, but it was at the point I last checked, 1,800 unique visitors as well to our digital hubs. So people are interested enough to kind of log in and click through to see and read what is there. So I think it's a wait and see, Kirsty, and I hope when we bring the report through to hopefully in the next public board, we can talk about what we've learned and what we're going to do differently for the next ages. I hope that answers the question.
Yes, thank you very much, Deb. That's great. Appreciate it.
Okay, well, thank you, Deb. Chris, you want to come in?
Yes, I just wanted to build on that point that Kirsty had made in relation to the engagement, and I'm drawing on experience of other engagements of where we've had a reasonable response and uptake, but the group that seems to not then be picked up on is young people. And I just wondered whether there's any consideration of how you engage, you know, I'll say secondary school on there. And the reason for saying that is because there is now an increase of them being able to get engaged in voting. And it's going to be the future that we're going to be dealing with. And I just wondered of whether we've noticed any particular interest within the younger age group, so go say from 15 to 25 or even 30, to see what we're capturing there, because that generally, when I've seen previous engagement, has been an area that is lacking, and it's really important that they have their say about the changes that could potentially come through.
Thanks, Chris. Really important point. You know, this is the future generation, and we'll have different views probably about how services could look, how they would wish to access service, and certainly kind of use of digital, etc. I know that there was engagement with young people, whether that was through schools or other forums. I think I would need to go back and check, but I think when we look at all of the responses, and you know, in particular 100 responses from the public, I'm not quite sure where that would sit in terms of demographic. I can see Claire has also put her hand up to come in, so she might be able to offer some further kind of insight and response. Thank you.
Thanks, Deb. So we'll go finally to Claire, and then we'll need to move on to the recommendation for this item, but please come in, Claire.
Yeah, thank you, Chris. And I think, you know, I really welcome you highlighting that we need to really be very proactive in getting the voice of both children, you know, young adults and young people is incredibly important. Clearly, during this phase of engagement, we've been particularly focused as well around care of older people. But of course, many of our children and indeed young people may also be young carers. So it's really important that we get the feedback through any of our carers forums. So I think it is about us maximising existing forums that we have in addition to our engagement processes. We do also have a junior Startwell board that supports the Startwell joint partnership space. So we will be looking to be able to maximise those areas of engagement as well. Thank you.
Thank you. So let's go to the recommendation, and that's that we receive and take assurance from the Better Together programme Stage 2 engagement update. Does anyone not support the recommendation, please? That too is supported unanimously. Thank you. Item 3.6 on our agenda focuses on the temporary service changes, and colleagues will remember that as a board we approved these temporary service changes last autumn, and since that approval we have received regular updates at each of our board meetings in relation to those changes. We've also been very clear that we would evaluate the impact of those changes after 6 months of implementation, and it's that report and that information that comes to this meeting for our attention and for our consideration. I'm really pleased to say that we started this meeting with some technical difficulties that prevented the Regional Director for Llais, the Citizens' Voice body in Powys, to join the meeting. But I'm delighted that Katie has been able to join and is now in the meeting and part of the meeting. So Katie, before we come to the presentation and discussion, I just wondered if you might like to share a Llais perspective on this item and on the temporary service changes and the engagement and conversations that you have had. Please come in.
Diolch, Carl. Thank you very much. Yes, I mean, just as I say, whenever I contribute, really, just to remind people that Llais is an independent statutory body and obviously not part of the decision-making process here today at the board. I think from our perspective, you can see in Annex 1, we committed to visiting all 4 wards where these temporary service changes were being implemented. And I think it's fair to say, and I hope you can see from the short summary that I've provided, that actually they were very, very, on the whole, very, very positive visits, and patients clearly felt that they were receiving a quality and improved service. I've also included some comments that we picked up, and again it's what we've heard and not what we think, that patients and family members have made where there are potential areas for improvement and consideration going forward. So I think that would be helpful if that was incorporated into reviews going forward. I think we haven't picked up anything specific around the closure of the MIU, other than to say, and it's not a surprise to anybody and it's not directly related to Powys, that there's a general feeling of services being reduced in rural mid Wales. So we haven't picked up any complaints and we haven't picked up anything specific around the closure of the MIU. I think from our perspective, the key going forward will be how, dependent obviously on the decision that the board takes today, how a change or a temporary service change or the situation going forward is going to be communicated with those communities that have been impacted by these temporary service changes. So that engagement and the communication, we would be keen to see how that's going to move going forward. I think it's also important to note that I've sought clarification from the executive team that the proposal to realign the temporary service changes, should the board make the decision today with the Better Together programme, I've sought assurance that that is in line with the Welsh Government guidance for service change. So I think if you see the report, we received some very positive feedback, and I think that's probably all, Carl, from me.
That's really helpful, and thank you, Katie. So we'll go now to our Executive Medical Director, to Kate Wright, and you're going to speak to the report itself, Kate. Thank you.
Thank you, Carl, and good afternoon, everybody. I'm Kate Wright. I'm the Medical Director. I think we have some slides that will appear just to support. So obviously you have the paper, but what I will do is summarise and draw out the most important points, and obviously invite questions afterwards. So as Carl, as you have summarised, then we have had our 6-month period of temporary service change. At the beginning, then we agreed that we would have a period of assessment and evaluation with an agreed framework and decision-making criteria, which would allow us then to, having assessed those, bring recommendations, which is what we're doing today. So in terms of the evaluation, first of all, then there has been active monitoring against the agreed measures, and it were put in place. We had dashboards gathering key data, surveys of key stakeholder groups, patients and staff, and monitoring of incidents and concerns. Evaluation has been carried out as agreed and planned. However, just to note that there were some challenges with outcome measurement, which are described in detail in the paper, and I'll go into in a bit more detail later on. Mitigation plans were implemented and all the mitigations have been completed. Decision-making criteria were agreed with each work stream, and they've been used together with the wider evaluation to make the recommendations. And important to note that as part of the final evaluation, we held a workshop, including staff that were actually delivering the services on the unit, and felt it was important that they were able to see the data, the information, and appraise it, check and challenge it for themselves. So moving on to the findings. So for the MIUs, the findings have been positive. So it has been workforce utilisation has improved and expenditure has reduced. There's been no use of agency staff and a reduction in the use of bank staff. Staffing cost reduction has been 9% across both sites. In Brecon, the cost per patient has decreased from £69 to £51 per episode, and in Landod from £63 to £54. Lone working had been a real concern. Staff working at night, that has been abolished. And another key driver for the change was that we had had a significant number of unplanned ad hoc closures. So to say that there has been no unplanned or ad hoc closure since the changes were implemented. There have been one planned full closure for a day and 2 further reduced hours in Landod due to staffing changes, but they were planned and able to be communicated in advance. And just to recap, then in the period prior to that, in the 11-month period, then there had been 6 ad hoc closures in Brecon and 32 in Landod. There had been concern about increased attendances to primary care. There have been no increased attendances to primary care, and there's been no increase in new ED attendances out with the county. Looking at the co-location units, so first of all, for the ready-to-go-home units, there's been around a 50% reduction in bank and agency costs. There's been a reduction in length of stay by about 23% compared with the same period in 23-24. There had been concern that it would be more difficult to step up admissions from the community into those units. The number has actually increased during this period. And over the recent months, there's been a reduction in patients delayed in out of county, DGHs, which has reduced a reduction in requirement for the ready-to-go-home unit beds. Looking at the rehabilitation units, again, there's been about a 50% reduction in bank and agency costs. The length of stay has reduced by 7% compared with the same period in the previous year. There's been an increase in patient flow through the ward in Newtown. Noting in the 6 months prior to the change, there were 28 new admissions. In the 6 months during the change, that rose to 49, showing that we've got an increased throughput through that rehabilitation unit. We've been able to admit individuals with more complex needs for early intensive rehab, and there is evidence of increased therapy input to the patients on the units. Just a summary of the findings and the system in general, so including the co-location. So we know there's been an overall reduction in length of stay by about 23%. There's been a reduction in out-of-county expenditure in the DGHs, and there's been a reduction in DGH bed days in both South and Wye Valley Trust. One of the things that we were aware of, we expected that if we did find an improvement in flow and efficiency in the co-location units, that would be expected then to have a knock-on effect to the whole system. So one of the challenges was the small numbers that we knew we would see during this short period, but also the challenges of trying to tease out in a complex system whether these changes and these improvements are truly a result of co-location or whether it's just a result of other system changes. And for example, we've had overseas nurses introduced, and there have been other initiatives to improve flow. What we have seen is a greater effect in the co-location unit, so a greater reduction in bank and agency, and a greater improvement in flow on the ready to go home units. I think we need to be really honest and cautious. The numbers are low, but I would say from the information that we have appraised, there is evidence that some of this effect is a true effect of the co-location rather than the system in general. But obviously a longer period of evaluation would help us be more confident about that. Outcomes. So we mentioned outcomes earlier. We set off with several outcome measures that we wished to look at. Clearly, outcomes are really important to us. We have learned that we need to do more work until we reach a level of maturity to be able to really accurately and properly monitor outcomes. EQ5DL is a general outcome measure which is validated, and we had used in pockets of the organisation prior to this, but I think we've learned that we don't quite have the maturity. Whilst we have collected that data, the numbers were low, and we have looked at those and appraised them, and they've not been meaningful enough to help. So that is something that we need to work on as we move forwards. We had planned to look at frailty scoring. That didn't progress because when we really looked at that in more detail, it's not validated for the use for the purpose that we were going to use it. So we chose not to. DigiFlow is the electronic system that we've introduced to the wards, which monitors patients' flow and where they are in the system. That was being rolled out at the beginning. Its use was low at the beginning. It has improved. So we have some DigiFlow data, but the numbers remain low. And also the SNAP data, which is the stroke outcome data, is collected and has been collected for some time. Unfortunately, during this period, changes to the national collection have meant that out with our control, have meant that data is not yet available for this period. We'd hoped it might be ready for this board, but it isn't, and it will be appraised as soon as we had it. Having said that, the available DigiFlow data does suggest that there is a decreased dependency on discharge from the ready-to-go home units. There is an increasing trend of patients being discharged on pathway 1, which is the lowest dependency. There has been a sustained reduction in length of stay, which we haven't ever seen previously, and that is an important established proxy measure for a reduction in patient deconditioning. And there's been a reduction in pressure sores from 55 cases in the previous interval to 38 cases in this interval. So we do believe that we've therefore seen evidence of improved outcomes during the period of change. Patient and staff experience. So we had surveys of staff groups, patient groups, and third sector primary care and social care, and all those have been collated. And we had reps from most of those groups, and obviously Light as well at the evaluation meeting. The staff, I think, really need to be commended. It has been a difficult time. Change is always difficult, but I'm first to say that one of the things that really came through at the workshop is the enthusiasm and the dedication that staff have dedicated. They really have embraced this. We're still going through a period of change, and we have more work to do, but there was an overwhelming sense of enthusiasm and engagement, which was really fantastic. So the MIU staff had expressed initial concern around communication during the engagement, which we've discussed previously. However, during the evaluation, there was a real sense of staff satisfaction due to the removal of lone working, a more reliable service, and more opportunity to engage in training. There've been no patient concerns or serious incidents arising as a result of the temporary changes. And primary care colleagues had been concerned that they may see an increase in GP attendances. However, they have fed back that they have not seen the increases that they had anticipated. For the co-location units at the workshop, it had been highlighted that there'd been a concern around loss of skills, and that remained a concern for some staff. However, there was also real enthusiasm at developing new skills and new systems. There had been concern around increased staff turnover, but that's not materialised. There's not been an increase in concerns raised by patients and staff reporting positive patient experience. And again, that came through. There were patient interviews, and that was reported by staff in the workshop. There's been constructive feedback from primary care during the rollout. There had been some issues with communication around admission, mainly to the ready to go home units, but transfer between the wards, and that has enabled us to learn and refine the system. A small number of patients, GPs and families have raised concerns around distances travelled from home, but others have appreciated earlier repatriation to Powys from a more distant DGH. So that brings us to the options and recommendation. So there are 3 potential options outlined here. So one is to immediately return to the model of care prior to the temporary changes. The evaluation has not identified any issues to warrant an immediate return to the previous model. There's evidence of improved practice and efficiency, and therefore this option is not recommended. The second option is to continue immediately to further engagement and consultation on the temporary changes, noting that permanent decisions in relation to the future models of care in Bronckhorst, Leonard, Lloyds, Brecon and Newtown can't reasonably be made out with a wider discussion around the Better Together work that we've just discussed in the item before. Therefore, this option's not recommended. The third recommendation option is to make decisions on the overall future of model of care through the Better Together programme, with the temporary changes remaining in place. As we've said, there are clear interdependencies between these temporary service changes and the wider strategic programme of work underway through Better Together. It's strongly recommended that insights and learning from the temporary changes are fully considered as part of the Better Together programme, and that future decisions on the community services are made through this wider programme rather than in isolation. It's therefore recommended that the temporary changes remain in place, with the decision on the permanent future shape of the services to be made as part of the ongoing engagement and consultant on the Better Together programme. Thank you, Carl. I'll happily take any questions.
Much appreciated, Kate. Thank you very much. So colleagues, please indicate if you would like to contribute to this item in response to the information that has been shared with us. We'll go initially to Ronnie.
Just trying to unmute. Thank you, Kate. Very helpful report and very helpfully presented. I just have a small number of comments in relation to the MIU specifically. And as always, Kate, if I require correction on any point, I'd be grateful if you would do that. On a personal level, I don't necessarily take a great deal of comfort from lead entries on a DATEX system. It might mean that there are no DATEX issues, but it also might mean that some which should have been recorded have not. And I just wondered if we'd had the opportunity to look at that in detail. Then secondly, very pleased that there have been no incidents of lone working. Ultimately, that's much safer for staff and much safer for patients. But I just wondered, when you say that lone working has now been abolished, if there were lone working in the future at any point, would that in fact justify a DATEX incident? And then in relation to MIUs and has patient safety improved, the comment is made that staff have reported that they felt patient safety had improved. I just wondered, has there been any attempt to get underneath that in terms of what patients might think? Because it's important to know that patients feel safe in that particular scenario too. And on those points, I'll rest. Thank you, Kate.
Thank you, Ronnie. All really welcome and important questions. So in terms of the DATEXs, I think we agree we really do encourage them, but we know that not everybody does report on day ticks. However, that was one of the reasons for the workshop, in that we had staff with us and we could ask them directly. And also, it's not just been an exercise of looking for day ticks and looking for concerns. There's been triangulation in terms of speaking to the sort of ward, the department managers and staff, just to make sure that that is triangulated. Is there any softer intelligence coming through that we're not aware of? So to our best knowledge, then there has been nothing. But yeah, so, and I think that's really important, and that's what we would do across, because we know everything does get reported. So it's about staying close to the service, and staff have been close to the service throughout. So I think we are as confident as we can be about that. In terms of lone working and future day ticks, then I don't know, but it's a good question and I will find out and suggest that. And in terms of the patient safety, then that is something that we again explored as to what did that actually mean. And I think what it really meant was there had been concern previously about, the ad hoc closures were a safety risk in that there was not a reliable service. So there was a very strong sense that the service was now reliable, that people would know when the units were open and when they weren't, and what the alternative options were. Part of the mitigation was to put out improved and strengthened comms on the services and what they could and couldn't deliver. There have also been a reduced incidence of people attending the MIUs with conditions that should really have gone to a DGH in the first place. So that was really the sense of that. And so, again, difficult to collect that on a quantitative measure, but that's why we have spoken directly with staff and remained engaged with them to get that on a qualitative basis.
Thank you, Kate, that's helpful. I'll continue to watch this with interest.
Thank you. So, Mick, would you like to come in, please?
Yeah, thanks, Chair, and thanks, Kate. So I think, based on the analysis in the paper, extending the temporary changes as you recommend feels like the right thing to do. But in parts, particularly as Ronnie says, around patient perspective, patient safety and quality, the case for, kind of extending is perhaps more narrative and a bit more subjective than we would probably need to see to make a definitive decision in the long term. And I understand the difficulties around short timescales, relatively small numbers, but more quantitative evidence would have been helpful in making out the case for permanent change. So just wanted to, some reassurance that, if the board does agree today to extend, that, in the longer term, we'll continue to build that evidence base, with more quantitative evidence if possible, just to give that, kind of crisper, clearer evidence base on which to base a decision as part of Better Together.
Thank you, Mick. And so, yeah, absolutely. So so what we have brought are, there is a significant amount of information that has been gathered. What we have brought are the sort of key, what we see to be the most important points and were related to the reasons for the changes in the first instance. There is more information that sits behind this. And what we haven't done is brought all the positives. Where there have been negatives, you will have seen them. So we haven't got a lot of negative information sitting by this. What I can say, having looked at this many times very carefully and having had it appraised in groups, is that what we hoped was that we would see improved flow and efficiency and outcome. I think the outcomes have been the more difficult thing, but we are starting to get there, and there is definitely a sense of improved outcomes for sure. There are many positives that we have found, and there are many things that may be positive, but certainly haven't changed or got worse, and we haven't chosen to bring those forward because they weren't there for material, if that makes sense. So we can show you that at a later date, but just to reassure you that is all sitting there, and we will continue. I think there's really important learning for our system. And so we have dashboards, for example, now, which are gathering some of this data, and I think that will help to inform some of the Better Together work. So I think it is important that we continue to gather some of this information, and we will continue to do that.
Thanks, Kate. Thanks, Chair.
Thank you. We go to Steve Elliott.
Thanks, Kate. A really good paper and really helpful overview. Just a couple of questions from me. Firstly, in terms of the concerns raised by staff around loss of skills, particularly in the ready-to-go home units, to what extent is that a real issue? And if it is, what actions are we taking to mitigate that? Because clearly we don't want to be in a situation where staff are losing skills, and particularly that'll have impacts on recruitment, etc. And then just in terms of, I can understand that there's been an attempt to seek the views of patients, but I just wondered, particularly again in respect to the ready-to-go home units, whether families have also been engaged, because obviously the aim is for patients to move out ultimately into the community, and families will have a role in that. So just has there been an attempt to gauge the views of the families as well? Thank you.
Thank you. So in terms of the skills, then there is no doubt. So they came through very strongly at the beginning. We have spoken to the ward managers about that and the staff. There remains a sense of that in some staff groups, and I've been to the wards and spoken to staff. I think, but what we haven't seen is staff moving. What we know, I think what we have learned is we know we have some people who are admitted to beds that could be looked after in a different way. So I think a really important part of the Better Together work is for the people that may need some enhanced care, can we use our staff skills and maintain them, but possibly not in the way that, not in the same working environment. So we know that there are some people who currently are admitted to a bed who could be looked after on an ambulatory day case measure. So that is one of the things amongst many that's been explored with Better Together, and that's what we are really encouraging our staff to come forward with ideas, is how do we keep these skills? How do we continue to deliver some of the care, but in a different way to currently? So we know that people sometimes are admitted for an iron infusion when that could be done as a day case. So that is a really active piece of work to say, can we maintain skills? Can we use the same staff and to help us deliver care in a slightly different way? So, and that's a very active conversation. In terms of the mitigation and families, I might bring Claire in to help with that, because she's nodding, so that's probably a bit closer to it than I am. So Claire, can you help with that question, please?
Yeah, certainly I can help with that question. I'm just wondering, Carl, if maybe the other independent members want to ask some questions. I've made some notes as I've gone along, and I can do a little bit of a summary, which might help.
Yeah, but so do you want to come in now specifically in response to Steve or others, or shall we come back to you later, Claire? Is that what you're suggesting?
Yeah, I think that would be helpful. I can try and pick up on all of the points.
Okay, that's fine. So we have 3 other colleagues wanting to contribute. So I'll invite Kirsty, Jen and Chris in that order to do so. And then we will go back to Claire and to Kate for some final observations before we move to the recommendation. So please, Kirsty.
Thank you, and thank you, Kate, for the paper. Firstly, on the MIUs, it's very reassuring to see that there has been no increase in workload for GPs and no increase in attendance at ED departments, which of course is what was very concerning to everyone. But I do wonder whether we are keeping data with regards to how often people who do arrive at MIU, either after telephoning or just arriving without notice, are subsequently sent to ED, and whether that is appropriate, or whether there is more work to do in explaining to the population about what minor injuries is and is not for. And with regards to the ready-to-go home units, to talk to the point about skills, the reason why we have these units is because those individuals are clinically optimized, although they still have some care and support needs. And we heard at the very beginning of this meeting today about the wonderful services that we can deliver in people's homes by highly qualified staff. And I just, to speak to Kate's point about whether there's more that we could do to avoid admittance into a bed. It seems to me that, this is helping us with the whole system, especially if we have people out of county who can be brought closer to home and cared for at the ready to go home. But in a way, the ready to go home is still an admission of a failure of the entirety of the system, because they should be at home. If the clue is in the title of the unit. So I just wonder as well whether we have actually been able to reach our aspiration. When we talked about this, we talked about an MDT approach and a whole system approach to supporting individuals in the ward. We talked about the voluntary sector, for instance. Some of the voluntary sector staff being there to be able to support patients and their families in terms of next steps and services that would be available within the community. We also talked about making life easier for our local authority colleagues in terms of carrying out assessments, and that's not really covered in the report. And I just wonder whether in the 6 months we've been able to reach those aspirations of that whole system wrapping around individuals at the ready to go home units, or is that still work in progress and an aspiration that needs to be delivered? Thank you.
Thank you. Let's go straight to Jen as well. So we're making a note of these, and certainly we'll get some responses in a few seconds. But we'll go to Jen.
Thank you. And like other colleagues, Kate, thank you very much for this very detailed report. I think there's some very compelling evidence in there of the positive impacts these temporary changes have made. But notwithstanding, further sort of detailed work, etc., I understand that, and hence the recommendation for it to then move in to be part of our phase 1 of Better Together potentially. For me, I got quite a bit of a specific question. It's to do with the feedback in section 3.7, feedback from the primary care, social care, and third sectors, and there was some quite candid feedback there, that was good to receive. I was particularly struck by the comment about the perceived need for therapists. So this is a very specific issue, but what was behind that? Is there a misalignment or a misunderstanding, or a misunderstanding or not clear about the role of therapists in the ready to go home units? So just a little bit of clarity about that I'd be grateful for. And if so, what are we doing about that to try and rebalance those expectations? Thank you.
Thank you. And finally to Chris.
Yeah, thank you, Chair, and thank you, Kate. I think the report is really helpful in helping make a decision moving forward. One of my experiences is that if patients are asked on a ward environment about are they happy with services and stuff on the and the care, they'll generally be very helpful, and it's sometimes the environment where they're asked those in questions will then give you a different bit of a different answer. So if this is moved forward to the Better Together, and we're looking to build a more evidence base, I just wondered if there's a different way of being able to capture patient perspectives on it, as has been previous in some of the other questions, families and carers' perspectives as well, because I think that will give us a more honest viewpoint to it. The other one is about the improvements in the relationship with the local authority around those assessment processes. I think that does need to be just unpacked a little bit more if that was there. I know within Katie's report, she'd indicated that there had been some questions raised about care packages and the timeliness of that on there. So it's how does all of that come together as a part of that? And I do note that you have made some notifications of savings, but you've done that as a percentage. For the general public, we may need to just show what that looks like, because that then will give us that we're not spending that inappropriately. It can then go to other areas of delivering rural healthcare in a more effective way, because there would have been a benefit of reducing length of stays in district general hospital beds, for example. Where is that captured? I don't necessarily got that from the report in the same way and I'll stop there, Chair.
Thank you. So we have a number of executive colleagues that want to respond, and we also have the Director of Social Services, our associate member of the board, Nina Davis, who wants to respond as well. So I'm conscious where we are in the agenda. So if I could ask colleagues for really important responses, but as succinctly as possible, please. Let's go initially to Nina. Would you like to come in first? And then I'll go to Claire Roche, Claire Madsen, and final observations to Kate Wright.
Thank you, Chair. Hello, good morning. Nina Davis, Director of Social Services and Wellbeing for Powys County Council. Firstly, thank you, Kate, both for the report and for the presentation. It's the first time that I've seen evaluation kind of data from the ready to go home units and the minor injuries. So pleased to see that. And as I was pleased to hear you said in response to earlier questions about there's additional data behind that. So I look forward to seeing that through part of the Regional Partnership Board in due course, etc. And also in terms of that output and impact as well, I'm really keen to pick up on that as well, because that's really, really important. I just wanted to give some comment and assurance in terms of the local authorities' involvement. There is a note within there about the potential early stages consideration of social care involvement on those wards. There was early stages conversations about that. Because but the criteria of the wards is that assessments are undertaken before. So one of my questions or comments was, is the criteria perhaps going to be rethought of in the extension of the pilot? Because I think that'd be something we'd be keen as a local authority to look at again with you. And I just wanted to give the board assurance that we are now putting in a dedicated hospital team where we'll be having named individuals assigned to hospitals and wards. So to be having that kind of familiar face on wards, etc., to be supporting the ready to go home units and the multidisciplinary approach as well. So just wanted to give very briefly, Chair, that assurance and support for the work, and also just that query around the criteria as well. Thank you.
That is really helpful. Thank you, Nina. So Claire Roche, please.
Okay, thank you, Chair. I'll do my best to try and assimilate all of those questions because there was a lot in there. But I think I'll try and respond in under a couple of themes. So if I focus particularly on patient safety, and I think, Mick, you raised a really good point there around the requirement for quantitative data as well as qualitative. And we certainly have recognised that during the period of time of this evaluation. I think it would be fair to say that not only have we been evaluating against a number of criteria, but we've also absolutely been learning during this evaluation, and that learning will go forward into the next phase. But I just wanted to reassure you that from a patient safety perspective, there are a number of ways that we would measure patient safety, and that absolutely is around patient safety incidents, nationally reportable incidents, in addition to concerns, complaints, and indeed compliments, because those are equally as important, and we probably need to improve how we report on that and capture that information. In terms of patient experience, I do completely agree that we need to ensure that we are consistently maturing the way in which we get really honest and really frank feedback from the people who use our services, and that is not just related to ready to go home units, the rehab units, or the MIUs. And I do take the points that both Steve and Chris and indeed Mick made about that. Very importantly, in the last few months, we have appointed a People's Experience Coordinator, which is a new role into the organisation, and we haven't had that role previously. And I would certainly be looking to that role supporting the next phase of this piece of work, and to be able to ensure that we have multiple ways of capturing both the patient's feedback, but indeed the family feedback. So we will take that on board. In relation to staff skills, that has been something that from a professional nursing perspective, I have been very alert to, recognising, of course, that this was a temporary service change, and therefore we were not realigning the workforce requirements for the Ready to Go Home units. However, I have been in conversation with Deb and her team, particularly around the Aspiring Nurse programme and where we place those nurses, and indeed how we consider rotational opportunities for our staff. That is a conversation that we have had prior to the establishment of the Ready to Go Home units, and something that now needs to be looked at in the professional development plan and professional progression plan, not just for nurses and midwives, but for the multidisciplinary team. And then in relation to admission avoidance, Kirsty, what you raised, I think that is absolutely core to the Better Together programme, very, very core to the community and frailty work stream that we already have established. And you're absolutely right. In an ideal world, we wouldn't need to have a Ready to Go Home unit. And we do indeed need to be ensuring that we're not only avoiding admission to hospital, but that we're having a shorter stay as possible in a hospital and a return to discharge in a home environment, which absolutely is the key to avoiding deconditioning. I hope I've managed to answer some questions in that, Carl, but I'm sure that Claire Madsen will be able to come in on some of the therapy aspects.
Thank you, Claire.
Thank you, Chair. So if I pick up Jen's question specifically around therapy, if we remember back to the original premise of this piece of work, one of the issues we had was that therapists were spread quite thinly across all of the wards, and they were spending time travelling between wards, and we wanted to concentrate the wards so that all the people requiring rehabilitation were co-located and they could have the maximum amount of therapy time. And as you can see from the outcomes, that's been really successful. There has been some feedback from the Ready to Go Home units that patients have wanted more therapy. I think there's probably two issues there. I think the therapists are victims of their own success. The patients quite like therapy and they miss it. And I think that's been one of the issues. All patients who need a programme have been assessed by the therapist, and they've been given a programme that they can either do independently or are supported by our rehab workers to do. I think patients don't sometimes realise that's actually having therapy by a qualified person. Maybe there's more that we need to do to pick that up. And we've also been working with nursing staff to give them competences in rehabilitation if somebody requires extra motivation or something like that. But we will continue to work on that communication. And lastly, just as a reassurance, if somebody deteriorates in the Ready to Go Home unit, or if something happens and they need an extra period of rehabilitation, we can take them back to the rehabilitation unit and give them intensive rehabilitation again. So we are really aware of those therapy issues, and those seem to have been the main reasons that we've had the feedback that we have.
Thank you, Claire. Kate, just before I come to you for a final observation, and I don't know whether Hayley might like to just come in on this as well. So the recommendation is essentially that we extend the temporary service changes because it wouldn't make sense to enter into consultation about them becoming more permanent or longer term at this stage, because we have a wider programme of transformation underway. We just talked about Better Together, and actually this therefore needs to be part of our Better Together approach. And whilst I certainly can see the sense in that, I think one of the things I'm very aware of is that when I speak to people and patients across the county, they do often raise with me instances where temporary service changes in Powys have gone on a long time, and therefore the question is, well, they're not really temporary anymore. And so I just wanted an assurance that this isn't again a kind of kicking of the can down the road, and that we will actually be rolling this into the Better Together programme, and decisions will be made very, very soon as part of that programme, as we have discussed earlier in the meeting. So I just wanted to seek that assurance in this meeting, please. Sean, I don't mind who comes in first. I can see your hand up, Hayley. Please do.
Yes, and I'd like to give the board full assurance that that is definitely the case. What I've heard very clearly from the start of when we started to share with the public about the need for temporary service changes, an absolute passion and appetite to be engaged and consulted properly on any permanent changes to the model, and that will be part of the Better Together plan going into the autumn. And so just to give you that full assurance, that's part of the reason in trying to ensure that we do that, to enable the public the full opportunity to help us shape those options for the medium to long term.
Thank you, Hayley. Kate, any final observation?
Just thank you to everybody and for all the questions. I think we've answered all the questions. Kirsty, I can just see we didn't talk about redirects to EDs. They are collected. I don't have the data in front of me, but they are routinely collected anyway, and there has been no change in this period. But just in general, I just again want to really extend my thanks to the staff. This has been a lot of work. But there's been a huge amount of learning, in terms of the engagement, the rollout and the evaluation, which is really, really valuable. It is already and will help to inform Better Together. And there have been some huge positives. The staff have been absolutely brilliant. It's not been easy. Change is never easy, but they have embraced it. We've seen amazing leadership and engagement from our staff. And I just would like to commend them for that. And I think that's my summary.
Thank you, Kate. And so we move to the recommendation, and that's that we receive the evaluation of the temporary service changes, that we approve that the temporary service changes remain in place and are subject to public consultation in line with the Better Together transformation programme during the autumn of 2025. Colleagues, please come in, please indicate if you don't support the recommendation or any part of it. That therefore is supported unanimously. Thank you. Now, we are due for our lunch break. In fact, we're a little overdue for our lunch break, but if I could just prevail upon you for your attention just for a few minutes longer, because I think if we were to take items 3.7 and 3.8 on our agenda before lunch, my assumption is, and it is only an assumption, that those items may not take a long time, and therefore we can deal with them now and then break for our lunch afterwards. So 3.7 and 3.8 together, which is the Director of Corporate Governance report and the amendments to our standing financial instructions. And Helen, I think you're going to introduce these to us.
Thank you, Carl. I'll just give a very brief overview of firstly my Director of Corporate Governance report. So a few areas covered in here. Our commitment to public awareness and transparency about our board activity. So that is summarised at the top of the report in terms of board activity since the last formal in-public meeting of the board in May. Chair's actions, approvals outside of the board environment. These are relatively rare. There has been one undertaken since the last meeting of the board, and that was about the commencement of the procurement for general dental services. That was taken in line with our standing orders, and the board are asked to ratify that. Committee membership, Carl, you and I have undertaken some work with input from other colleagues. We have reviewed independent membership across our board committees, taking into account a number of factors that are summarised in the report. That is also presented today for the board to ratify in line with the requirements of our standing orders. Board and committee effectiveness, I gave an update on this in the last board meeting. This is now the culmination of all of that information together, including the board's assessment of its own effectiveness that was undertaken within a recent board development session. And you can see in the report the areas outlined for board activity priority during this financial year. Carl, you asked me earlier on in the action log to comment on the Healthcare Professionals Forum. We have developed the terms of reference for that advisory group to the board. We have identified a chair and we're just working through the appointment process for that. And we have 2 dates that we're working on to try to secure the first meeting. It is later than we'd hoped, so with apologies for that, but we hope the first meeting will take place in September. Those terms of reference and full update will come through in my report at the next board meeting. In terms of my second paper, the standing financial instructions, so we've received a Welsh Health Circular from Welsh Government outlining the requirement to adopt this amendment to Chapter 11 of the model standing orders. This is in relation to procurement and contracting and brings up to date our rules in terms of the Procurement Act from 2023, which came into force earlier this year in 2025. Our Audit and Risk Assurance Committee received these underneath its consent agenda and didn't raise any concern to bring to the board's attention. So the board are asked to approve those amendments to the model SFIs. Thank you, Carl.
Thank you, Helen. Colleagues, does anybody want to contribute and to respond either in relation to Helen's Director of Corporate Governance report, or indeed to the changes to the standing financial instructions? Ronnie, please do come in.
Thank you, Carl, and thank you, Helen. Helen, you've rightly laid emphasis at 3.8 on the need for public transparency. This is just an observation, Helen. When I look at 3.8, I recognise there's an important process there, and there are ways that this has got to be approached, but much of the language in here is quite dense, and my observation would be that it's maybe hard for a member of the public to actually follow that through. Having said that, I'm not sure what you can do in order to improve it, but it is an observation that I think in terms of public transparency, it isn't necessarily particularly easy to read. And I hope you take my point in the constructive spirit with which it's intended. Thank you.
Thank you, Ronnie.
I do, Ronnie. Thank you. Just to check 3.8, the standing financial instructions you're referring to. Yeah, I agree with you. Their model that as you know, their model versions received from Welsh Government and often based upon legislation, which, as you rightly say, is complex and tricky. But point well made and understood. And I'll take that away and talk to Welsh Government and see if there's anything we can have a think about in terms of making some of that clearer to understand for everybody. Thank you.
Thank you. I can't see that anyone wants to contribute, so we'll take each of the agenda items separately. So in terms of Helen's Director's report, we are asked to receive the report. We're asked to ratify the Chair's action taken on the 3rd of July. We're also asked to ratify the Board Committee membership as set out for 25-26, and to take assurance that Board and Committee effectiveness reviews have taken place from 24-25, and that a governance development plan is in place for 25-26. Colleagues, please indicate if you don't support the recommendation. That too is supported unanimously. And under item 3.8, the standing financial instructions, that we approve the changes to the model standing financial instructions in relation to Chapter 11, procurement and contracting. Does anybody want to dissent from supporting the recommendation? That also is supported unanimously. Thank you. And so we will break now for, I think, a well-deserved lunch break, and we will reconvene, please, at 1:30. Thank you. Wel, croeso nôl ar ôl ein hegwyl ginio. Hyfryd eich gweld chi unwaith eto. Felly, dyn ni'n pigo'r agenda i fyny ar eitem 3.9. Ac dwi'n gwahodd ein cyfarwyddwr iechyd gyhoeddus i gyflwyno'r eitem yma i ni. Felly, we pick up our agenda again at item 3.9, the Regional Partnership Board Annual Report for 24-25 and its forward look. And